Thanks, Chair. We can start.
Okay, thank you, and welcome everyone to our meeting here of the JOS, the Joint Health Overview and Scrutiny Committee, North Central London. I'm the Chair, I'm Councillor Pippa Connor, and welcome you to the meeting. This meeting is being recorded. We're on Teams, so just be aware that anyone who does contribute to this is being recorded, and their views will be heard widely, I hope. So I'm just going to begin by asking members to introduce themselves. So I'm going to sort of read out the names, and then if they can just come on to the call and unmute and introduce themselves. So I've got Councillor Clark.
Hi, I'm Councillor Tricia Clark from Islington. I'm on the Health and Social Care Scrutiny Committee in Islington, and I'm Vice Chair of the JOSC.
Thank you. I've got Councillor Cornelius. Councillor Cornelius, I know you're on the call because I've just seen you. Okay, we're going to come back to Councillor Cornelius. Councillor Freedman.
Sorry, Councillor Connor, I've just had an incoming phone call, so I'm with you now. But no, I'm fine. Okay. Sorry, that was the question.
No, it was just to introduce yourself.
Oh, sorry. Sorry. Hence I was on the phone. Sorry, I was just trying to clear that out of the way, so I'm with you now. So I'm Councillor Alison Cornelius. I am a Barnet councillor and I chair Barnet's Health Overview and Scrutiny Committee. Thank you.
Right, thank you. Councillor Freedman. Okay, I'm going to move on to Councillor Tomlinson.
Good morning, Paul Tomlinson from the Borough of Camden, and I'm on the Health and Adult Social Care Scrutiny Committee. Thank you.
Thank you. Councillor Armaz. I'm going to move on to Councillor Levy.
Yes, hello everybody, good morning. Councillor Derrick Levy, Borough of Enfield, Southgate Ward, and I chair the Health and Adult Social Care Scrutiny Panel. Thank you.
Councillor Boyd. Okay, I'm going to move on to Councillor Gantley. Okay, so what we're going to ask is if that when councillors come into the room, it could be noted, Fiona or Rob, whoever is sort of noting that for the minutes, and just to let me know, and I'll ask them to introduce themselves when they come in. That'd be great. Thank you. There's quite a few officers. Councillor Tomlinson.
Chair, the persons that you called, are they not present, or is it just the case they can't hear you? Can we verify if those people who are present can hear?
We can. Fiona, could you verify?
It's Fiona, the clerk to the meeting. So they're not currently in the meeting, but if they do join, we'll let you know.
Thank you. Yeah, that'd be great. Thank you. Just to get some clarity for the meeting.
Chair, can I ask, is it just me that can hear this buzzing noise?
No, I can hear it as well.
I can't, but then.
So can I. Terrible noise.
Could you mute Pippa and just see if it's anything to do with you?
All right. Sorry.
No. Yeah, it's Pippa.
I don't know what we're going to do. Sorry, and my laptop it's not making noise my end, which is a bit disconcerting. Sorry. Okay, well, I'm going to just be very brief then in my introductions to everything, and I'm afraid you're all going to have to sort of do loads of questions and responses today. Then there's going to be a lot on you. So I'm going to whip through this quite quickly if I'm causing problems. Sorry, I can't sort that out from here. So I'm going to go to Councillor Cornelius. Councillor Cornelius, you put your hand up. Okay, I'm going to move on. So I've got apologies for absence from Councillor Reaver, so I'd like those to be minuted. And just a note to the panel that's on, officers will be introducing themselves per the item rather than just introducing everyone now. Any urgent business, Fiona?
No urgent business, Chair, but I have just received apologies by email from Councillor Moyeed, so I'll note those in the minutes.
Thank you. Any declarations of interest?
None from me. That's which is me.
Okay, so I'm going to note that I'm a member of the RCN and my sister's GP in Tottenham because we're discussing GP practices later on as part of the winter pressures. So that's to note for myself. If there's no other declarations of interest, we're going to say I'm just letting you know that I had a request to vary the agenda. So we're starting with adaptations, then the elective service recovery, because one of the officers is only available until 11 AM. I've got Councillor Cornelius who wants to come in.
Yes, sorry. I just lost contact there. Apologies, Councillor Connor. That's why I'm turning off. I've been told by Barnett that if I turn off my camera, it doesn't use as much bandwidth. So I've got a much better connection. Otherwise, I was agreeing with Councillor Clark. There was a lot of background noise just previously. It's better now. Could I also you were just wondering, or Councillor Clark was wondering who was actually had said yes they'd come and who was going to be on the meeting. I know I brought this up before, but I do think there have been certain councillors who have not attended now for several years, may I dare say. Councillor Gantley is one of them. Could we please ask to have, sorry to be a pain, but I think we need to look at who is attending these meetings. And if we've got a councillor, it doesn't matter which of the 5 boroughs, just so I'm being completely, across the board. But if we've got a councillor who really cannot make it for possibly every meeting for a couple of years in a row, that they really need to come off, and that borough needs to have somebody else. And if it's my borough, very happy to go there. Anyway, I'm just going to put that out there. But okay. Councillor Gantley's attendance record, I think, has been a shocker. So I'm being a bit forthright this morning, but I know I brought it up gently in the past. So I'm, yes, now going there a bit more forcefully. But if anybody else has not attended for 3 or 4 meetings in a row, unless they're in hospital, got a really good reason, I think we do need 2 members from each borough. It should be 10 of us. And then obviously if we, one of us can't come or 2 of us, then it's just not a problem. Sorry. And Councillor Clark now wants to reply on that one. Thank you.
Okay, thanks. So Councillor Clark, if you could briefly reply, and then we'll note that as an action for the officers to take offline. Thanks.
Yeah, thanks very much, Councillor Cornelius. I just for information, Councillor Gantley is not standing again as a councillor, but I would really appreciate a letter from the chair to the whoever you deal with in Islington, asking for another member of this committee.
Yeah. I would agree, Councillor Clark. Thank you, because if he's not standing, it's not till May next year. So there are quite a few meetings between now and May.
Exactly, and I have raised it with various people, but I think it needs a letter from the chair now. Thanks.
Thank you. Sorry for interfering. Apologies.
That's fine, and that can be an action that I can take up with my officers, and we'll do that. So thank you, everyone, for that. That's very helpful.
Are you okay, Councillor Connor, if I turn off my camera now, because I'm getting a bit fuzzy again? Thank you.
Absolutely, although I think the apologies might need to come from my end. I think it's my laptop, so I have to take it in for a service. So we're going to go on to adaptations now. We've got adaptation from the NCL NHS Watch and Keep Our NHS Public from Brenda Allen and Alan Morton. They're going to have 3 minutes to address the committee. The total time for the entire adaptation, including questions, is 15 minutes. So I'm going to ask officers to keep an eye on the time. And then we've got Chloe, Sarah and Paul, possibly Joe as well, may be able to give a brief verbal response. However, this deputation has been taken as part of our winter pressures item, and quite a bit of the deputation is going to be sort of, or the concerns they raise do fall under that winter pressure item as well. So I'll leave it to officers to either respond now or pick up the deputation's points within the winter pressure item, because obviously you don't want to repeat it twice. So I'm going to hand over now to Brenda and Alan to introduce and let them decide who's going to speak, and then obviously we'll go over to questions. Thank you.
Could you just confirm, Pippa, how long we've got?
You've got 3 minutes to address the committee and then 15 minutes in total for the committee to ask questions.
Okay. Thanks for inviting us. So we wanted to talk about primary care in the context of winter pressures. Primary care sees 90% of patient contacts, and so it is really the face of the NHS. And when there are pressures on other services like A&E or hospital discharges, that just lands back on primary care. And patients are really anxious. This is the second year of COVID, restricted access, restricted services. And the news about the new Delta variant, the new variant today, is not reassuring. So we've sent you a paper. We urge you to urge the ICS, who we know are doing a lot of work, but there are constraints, on what more they can do to support primary care with its workload, workforce, stability of provision, and other issues. We've read all their papers on winter pressures, primary care committee and recovery. We think that's not going to be enough, and we wanted you to press them on what more they could do effectively. If there are constraints, what more they are going to do about those constraints, not just absorbing them with NCL, but pushing those concerns up to NHS England. And with you, as representatives of our communities, which are diverse, disadvantaged, elderly, what more you can do about the pressures within your own councils, pan-London, within your own political parties. So the issues are not just about workload and a workforce. There are issues of stability of provision with takeovers. I've written something about the Centene takeover, the arrival of mega practices which tend to focus on e-consult or even own the e-consult model. The other thing we wanted you to press for is GP representation within the ICS. So the workload, workforce and other pressures are unlikely to be responded to if GPs don't have a solid foot on the ICS. They only have one place now on the ICB board, and the GP Provider Alliance, we just don't think cuts the mustard. In terms of stability of provision, there are contracts coming up due for renewal all over the winter. I mean, there are contracts now that will be falling up for renewal and that NCL will be having to make arrangements for. What measures they're taking to ensure they stay with the NHS family, and if any large super practice is planning to do an AT Medics, what greater scrutiny can NCL offer so that it doesn't fall kind of victim to the sort of criticisms that have been, legal opinion have mentioned during the judicial review. Now, that's not about accusing NCL. We read their papers. We know they're doing a lot. But the fact is, it's just not going to be enough for this winter for primary care provision for patients.
That's 3 minutes, Chair.
Okay. I'll finish there.
Okay. Thank you, Brenda. Thank you. I pulled quite a few very interesting points from your deputation, and I think one of those that was I think you were going to maybe come on was the staffing issues as well, around the pressures for GP practices. We all know that there's very little, there's a huge amount of spaces for nurses and GPs that aren't being filled at the moment, and of course that's going to have a huge knock-on pressure as well. So again, these are wide issues. Some are local, but also to NCL, but also a lot are also across the whole piece. So I'm going to ask. I can see Paul and Joe that have come on, and Sarah that are on the call. Do you want to respond now, or do you want to take some questions from from us first as councillors, and then respond as part of that? Do you want to make an initial Joan?
Yeah, thank you, Pippa, and thank you, Brenda, for your detailed deputation. You know, the comments, the written narrative that you've provided with us. I mean, yes, I completely share everything that you've written, your concerns. I suppose, you know, we're very happy to highlight some of the themes of the pieces of work that we've undertaken, and as you've said, you've probably looked at many of the papers and the documents that underpin those elements of work, and obviously we will come on to that in the context of winter pressures. I mean, I will say that there are some very important and very serious themes that we are experiencing in primary care, and the concerns that you have basically present us with the dualisms of the fact that we have a recruitment problem, a retention problem. We have a growing number of GPs and staff, practice nurses, for example, that year on year the numbers are reducing. People originally have shied away from the partnership model, and now people are reluctant to take up a salaried model. And more recently, we were reliant on populations of locum doctors. And to be honest, you can no longer find locums. So my annual leave just in the autumn, instead of being with the family, I was in Durham with my family, but I was doing GP surgery because I couldn't find somebody to cover the practice. That is the reality of most of the practices in North Central London, in London and nationally. And I would say that, you know, we are fortunate in North Central London that we still do have you know, a population of GPs who are committed to carry on working here to make things better. So this is a really complex time. So, you know, the additional element is really, you know, how we support practices to stay resilient in the face of all of that. And so there are lots of initiatives that you have heard spoken about, and I've seen documented in the national press, endeavouring to try to sort of streamline processes and get people seen in the right bit of the system as quickly as possible. Now, what I'm most interested in, and we can certainly talk a little bit more about this in detail, and I won't speak for too long, other than to say the most important thing for us, for me, is that I have absolutely heard what our residents have said through attending health and wellbeing boards, through coming here. Yesterday, I was at the Islington Patient Participation Group. There is so much inconsistency across North Central London around how residents are able to access services. And one of the most important things for us to do is to get under the bonnet of that inconsistency, to understand where practices, you know, we had stories of practices' doors being closed. We've had stories of people not being able to get through on the phone, or practices that have used e-consult as a way to sort of streamline access into even speaking to a GP. Well, all of those things, you need to understand the narrative of why people have done that. And you know, we did find that there was one practice where the door was closed, but it was a sort of metaphorical closure, and it was because of the infection prevention control guidance and the problems with space in the practice, etc. So, you know, there is a program of work that is really getting deep and forensic into each and every practice to understand what those practices are experiencing in way of difficulties, and how we can actually develop a program of support. And that might be about administrative staff, because we've understood that about 45% of practices are experiencing problems with administrative staff. There's something about customer service training for receptionists, you know, to help them understand that actually their role is outward looking as well as supporting the GPs that employ them, etc., etc. So these are all really important bits of work, and what we have done is make sure that the packages that we've put in place are responding very specifically to those needs. in terms of what we each and every one of us can do, and one of the things that we're working out in our communities to really support people to understand is the benefits of immunisations, you know, so coming forward for the flu jab, coming forward for the COVID booster, etc., really trying to increase our uptake of vaccinations as much as possible, and then also working with our acute hospitals so that, you know, recognising that a lot of the work that's been happening in hospitals has been passed back to GPs, work with our consultants to help us sort of really work as a clinical community better together to get people into the right bit of the system for the care that they need. So, you know, there's still work to be done. We still face the recruitment problem, and sometimes, you know, it will be, how do we offer people, you know, working conditions that enable them to be more flexible, etc., etc. It's a host of interventions. One size doesn't fit all, and we are obviously escalating up to the region and also nationally as well. So, you know.
Okay, thanks, Jo. Thank you. That's been really helpful to get that. I know that Brenda obviously wants to come back, but I think we need to come back with questions first. We've got 5 minutes left, and I think questions will come back to the deputies now, to Brenda and to Alan. I'd just like to say very quickly that the officers were asked to provide a section on e-consult as part of the update on the winter pressures. Now, it's not in your pack because it wasn't available at the time, so the slides were removed and we're going to be given a verbal update. So if you've got anything on e-consult in particular, we can take that as part of the winter pressure, as in case you're wanting to use it or don't want to use it for 5 minutes. So I'm going to go quickly on now. I've got Councillor Tomlinson and Councillor Cornelius to ask questions of the deputies. Thanks.
Oh, thank you very much, and thank you for the presentation. You've been so helpful. It's very detailed, and honestly, you know, the times we've heard you have been really excellent. I wonder, Chair, if we can accept the recommendations that that have come with the supplementary agenda under paragraph 2. I wonder if we can accept these as actions going forward for our committee. I did have a general question about e-consult, and because my local surgery is closed, and it's not necessarily really to take up time with this now, possibly, but I'm just wondering what the deputy has if you've had any particular feedback that the closure or continued closure of practices is having any effect at all on how people approach their GPs. That's all. Thank you.
Okay, so thank you, Councillor Tomlinson. So that's a recommendation for the panel to think about the recommendations within adaptation to be taken as part of the agenda item for the winter pressures. So we'll have a look, obviously, that, and then we'll sort of go through that, and at the end of that we'll marry up the deputation's request for recommendations with our recommendations, and yes, see where we can agree at that point. I've got Councillor Cornelius, then I've got Councillor Levy, and then Councillor Clark. So if I take Councillor Cornelius next, and then you, Brenda and Alan, can quickly answer those two questions, and then give an opportunity to Councillor Levy and Councillor Clark to also ask questions. Thank you. So I've got Councillor Cornelius wanting to ask a question. I think she's having some problems with her connection, so I'm going to go on to Councillor Levy to take the question.
Okay, thank you. I'll be very quick. Sorry, I started, Alison, now, so I'll just be very quick. Both relating to the section 2, the recommendations. One is perhaps venturing an answer or a partial answer to the final bullet point. What could the ICS do differently with regard to greater scrutiny? My answer to that will be the thing I've been banging on about in this committee, in the Health and Wellbeing Board locally, and the Health Scrutiny Panel, which I think Jo would have heard me say last time she visited us, is that if we have greater grassroots member participation on whatever boards are set up under the new ICS arrangement, that is the means by which we'll give greater scrutiny to all practices, whether they're the American-owned ones or the larger mega practices. So there's one way of doing it. My question, Brenda, very quickly is that I do agree with the principle and the motivation behind the bullet point that says let's have greater primary care having a greater say in the services and representation on the board. I think the principle of it is fine, but isn't there a conundrum there in that for every hour or 2 or 3 that GPs sit in meetings like this or meetings like that or boards like that, they're taken away from the coalface and the front line in the surgeries, which is the very basis of the pressures that we're hearing about and speaks to the answers that we heard from Joe about retention and recruitment. And that there's a, again, I'm trying to balance the principle and the practice, Brenda. How do you feel about, on the one hand, accepting a recommendation that we should have more GP representation, which I think is sound, but the downside of that is that they're not in the surgery dealing with the patients and exacerbating the question and exacerbating some of the problems. And that's my comments. Thank you.
Yeah, I'm going to ask councillors to be quite brief and deputies to be quite brief. We've got 1 minute left for this item, so I'm going to allow a couple of minutes over because we've got 2 councillors who still haven't asked questions. So Brenda and Alan, I'm really sorry. Can you keep your answers brief? And then the other 2 councillors.
About GPs, the problem is that if they don't take time out from their surgeries to be on the committees that allocate resources, that decide the design of services, the problem will continue. It's the same with having patients and community reps on decision-making boards. If they're not there, the services are worse. I think one just has to accept that. And the answer is to recruit more GPs. And train more GPs and have more practice placements in our existing practices and support that. So next question. I hope that answers it. That would be how I'd balance that.
Okay, and I think there was a question about e-consult. So as I said, we're taking that as part of the winter pressures. But is there anything you wanted to come back very quickly on, Brenda, about the potential problems with e-consult?
Yes, I was thinking another deputation were going to do that. There is evidence that over-reliance on e-consult and other remote contact methods is quite frustrating even for digitally savvy people. I mean, I've heard of a professor of IT who couldn't manage e-consult and patient access because the system wasn't working. So it encourages patients to go straight to A&E or other places or sit on their problem until they get worse. And then they call in the emergency services. So the outcomes are not good. It's about having dual methods. Most people, when they're ill, will not fiddle around with a clunky IT system, one that takes you round in loops and all the rest of it. They need to pick up the phone and get an answer. So the effect is not good for patients. That's not to say that when it works well, many patients, particularly the fitter and the younger, quite like a digital option, but it should be an option, not the main way, which is what some practices are doing. Right, next one.
Yeah, thank you, Brenda. So I've got Councillor Clark and Councillor Cornelius, and then we're going to, I've got Alan, can you come in with Councillor Clark and Councillor Cornelius's questions and then pick anything else up that you wanted to add at this, the points have just been made. Thanks. So Councillor Clark.
Okay, I just want to pick up the point about contracts coming up for renewal and that they should stay with the NHS family. And that, you know, this A&G service that is to connect GPs and hospital specialists, and that it's about downgrading 65% of GP referrals. Just to pick that up, and also to support the Councillor Tomlinson's suggestion that we support the deputation's recommendations. But just about this, you know, how can we avoid, you know, what's the alternative to this this, you know, contract to A&G service?
Thank you, Councillor Clark, and I've then got Councillor Cornelius. I fear we might have lost.
Sorry. No, I'm here. Sorry. Yes, I probably bring my question up, but I actually went on e-consult after we'd had a meeting of our health overview and scrutiny. But if that's going to come up, Pippa later, Councillor Connor later, then I'll bring that in then. But it took me 16 minutes to go through with a dummy problem that I might have had, but then I didn't send it, but it did take me 16 minutes, and I was quite aghast at some of the questions being asked. And it would have been so much easier if the question had been, you know, is my problem serious? Do I need a consultation today or tomorrow in the next couple of days? Or can I wait for 3 or 5 days? And I would have just ticked yes, urgent, or no, I can wait. And then, do you want a Zoom? Yes, I do. Or no, do you want an in-person? Yeah, I do. You know, whichever. And that's it. Finished, over and done with. eConsult took me 16 minutes, and yes, and the questions they'd asked, and I did took a screenshot of the questions as a female. I didn't think that was relevant, but I'll discuss that later, because I just confessed I got a pimple on my face I was concerned about. But then I was asked, you know, age I put in. So if you want me to go there now, I put in my age, obviously my national insurance number, and, you know, I'm in my early 60s. Then it said, had I had a termination in the last 6 weeks? Had I had a miscarriage? I mean, it was just brilliant. And I've screenshot, so I've got the evidence of what they were asking when I said I was concerned about a supposed. Anyway, I'll go there very happily under the next item. But, you know, I think, you know, some people do want a Zoom, particularly if they've got children, and it takes them time to dress all 2 or 3 children. They've got them in the waiting room, taking them into the GP. They'd like a Zoom. That's fine. If I got some cancerous spot I was worried about on my back, you know, I'd like to have an in-person. So I can't see why. My understanding is that no GP surgery has dismissed their frontline staff who used to answer the phone pre-COVID. They're still there. And so why is it they can't answer the phone now? And if you're going to go either or,
thank you. That's really helpful. Unfortunately, we are running very.
That's fine. I'll go there with the next item. Thank you, Councillor Connor.
Yes, thank you. Sorry, we are running massively over time, and the next person who's coming to present on elective surgeries is only here until 11, so we're running hugely out of time. So I'm going to ask Alan to come back very quickly. Apologies, Alan, that your time's been taken, but I think I'm getting an understanding now of what the concerns are, and I think we can take that up as part of the winter pressure report. Thank you.
Yeah. I was just going to raise the question on the question of contracts. We hope that NCL is actually going to pay a lot more attention to its tendering processes, given what's happened over 17 and the judicial review that's happened. I just briefly wanted to raise the question of funding, which is obviously very important. The annual report of the CCG talked about the problems with getting funding for COVID-related matters back from NHS England. They've also mentioned there's a problem about the backlog of elective surgery, and they're also facing a capped budget this year. And these budget pressures will clearly bear down on all the winter pressures. So I just wanted to ask the NCL CCG what views they had about the budget prospects for this coming few months.
Right, okay, I'm going to ask them to hold off on answering you on those until we get to the report. So thank you very much to Brenda and Alan. Sorry, Brenda, I'm really sorry. We're going to have to stop there because we are. I've taken much longer than we were allocated for on this item, but I think we've got some very clear questions from the panel and really clear questions from yourselves and the written deputation as well. So as well as what you presented today. So I'm afraid I'm going to have to stop it there, but I am going to have to move on now to the elective. Sorry, I'm just looking on my pack. So we've got a elective service recovery. So I'm going to ask officers to come on to that, speak to that. Please could you introduce yourselves, and I know you've only got 25 minutes now to go through the paper. So I'm going to ask if you could understand that we've all read the paper. So a very brief, a minute or so introduction about the paper and any particular items, areas you want us to pick up on, and then we'll go straight to questions. Thank you.
Sure, thank you very much, and thank you for accommodating a slightly different schedule this morning for me. Just to introduce myself, my name is Ali Malik. I'm the Director of Elective Recovery for NCL. And I'm here this morning to talk to you about the progress we've made with our elective recovery, what some of the challenges are, and what some of the plans are going forward. So like all parts of the country, we've had quite a significant challenge with our elective services since the start of the pandemic. And that's because through periods of the pandemic, as we all know, there were times when we had to really reduce the amount of elective services we were carrying out to redeploy our resources towards the COVID response. And in addition to that, we've been implementing infection prevention control measures, which has also reduced the efficiency of our elective services by about 15%. And the combination of those two things has essentially meant our waiting lists have grown over the course of this pandemic. The number of long waiters we have has significantly increased as well. And by long waiters, I mean those waiting over 52 weeks for treatment. And even those that are waiting more than 104 weeks for treatment, so 2 years, that those numbers have also grown over the course of this pandemic. However, we've adopted the mantra of don't waste a crisis. And we've been, where we've had challenges with our elective services, there's also been significant opportunities for us to really transform how we deliver those services and how we can work differently across our different provider organisations. So I'll just quickly pick out a few key points over the course of the last 18 months and then open up for questions. Firstly, we adopted quite a rapid governance structure and programme around elective recovery after the start of the pandemic, so much so that we were the first ICS in London to be given permission to restart all of our elective services in summer last year. We've also opened up a new elective centre in the Grafton Way building, which is one of the UCLH hospital sites. And that's really focusing on orthopaedics and ENT, and we're getting some really good cases and activity through there now. We've created 7 clinical networks that cover our high volume elective specialties. And in those networks, we've been getting our clinical and operational leads from all of our different provider organisations together and really help solve this problem together. And we've already started implementing some really good radical changes in those pathways to really help get through those backlogs. We've also been nominated as an accelerator system, and we're the only one in London to get that status, and there's 13 accelerator systems nationally. And that came with some additional funding for us in this financial year to actually address and pilot some new ways of working and learn from how we can actually do things a bit differently. And so we've had 50 projects that we've been funding through that programme, and we've already started to make some really good inroads into some of those challenging areas we've had. Just as an example, we've been able to invest in a community gynaecology service, which has effectively meant we're bringing our hospital acute service and the community service much more closely aligned, so that we can actually see more of our patients through the community service and reduce some of that pressure on our acute hospital backlog. We've also been investing in excuse me, a primary and secondary care interface project management team, which effectively is working across both primary care and secondary care to resolve some of those interface type issues, and also think about alternative pathways for our patients to be on if they don't have to be waiting on those long acute waiting lists. We've also been investing in things like admin systems and processes and operational systems to really help some of the efficiency of those services and reduce the amount of appointments that do not get attended by our patients, but also ensure that we're most efficiently using the capacity that we do have. The final point I'll just make before I open up for questions is we've been investing heavily in a data system for bringing together our systems waiting list information. It's called our One System Patient Tracking List. And effectively what that does is all of our providers now have access to each other's waiting lists. So where we do see variation in those waiting lists, so if you're referred to one provider organisation and the other one has a far shorter waiting list, we now have the ability and mechanisms to help divert patients away from those busier hospitals to the less busy ones to even out the waiting time variation that we currently have across those different sites. So I'll stop there, but really happy to take any questions.
Thank you, Ali. That was really helpful, a really excellent whiz through, and apologies for sort of curtailing some of your time, and I know you have to leave. So I'm going to go straight to questions from colleagues. I've got hands up. I'm not sure if they're legacy ones from the previous questions. So I had Councillor Cornelius and Councillor Clark and Councillor Levy. So I'm just going to ask those 3 councillors to ask their questions, And then if you could take those two first, thank you.
No, I'm fine, Councillor Connor. It was previous. Thank you.
Fair enough. Councillor Clark and then Councillor Levy.
Yep, just about the investing in the data systems, where all providers have access to waiting lists. I just have a little bit of an alarm bell going about, who these providers are. Are they in the NHS family, these providers? And, is this happening sort of between hospitals? It just sounds it sounds a bit worrying, actually. So, they can just take people off waiting lists, willy-nilly?
No, so thank you, sorry, and I should have clarified. These are all NHS acute hospitals that I'm referring to. So we had quite an extensive period of consultation with our public.
I missed that. It was really bad reception. Could you just say that again? Start again from the beginning.
Sorry, Ali, before you start, so we've got Councillor Levy's question first. We're taking two questions at a time. Thank you.
Sorry. Okay. Thank you very much, Chair, and thank you, Ali, certainly for the oral summary and the written paper. It's very good. I'm very impressed by it. But the question I've got is that after the last year in which you're trying to develop a strategic recovery programme, how robust is it and how resilient is it to episodes like we're receiving in the news overnight and the last couple of weekends, and the contingencies you build in a way that if the current news is worse than we all anticipate, how might it torpedo all of this, or at least adversely impact all that you're trying to achieve? Because a lot of this programme has been developed in the calm, or the relative calm, of the immediacy of the first waves of COVID. So the question is, this is all very good and it's impressive and it's very well structured, but could it all go belly up, or words to that effect? Thank you.
Sure, thank you. Should I come in now to answer those two questions?
Yes, please, thank you.
Great. So firstly, on the point around the data system, so to give you some reassurance, this isn't a completely open platform for any provider to use. By providers, I'm referring to our NHS provider group. So within NCL, we've got our designated acute hospital providers. We've also got our primary care sort of services and our community providers and mental health providers. So this data platform is really for use for the NHS within the NHS. And the idea here is there's very strict criteria on what information is accessible from which person. So this isn't completely all patient identifiable information isn't available to everyone. It depends on different levels of access permissions, depending on what that information would be used for, which is under a data sharing agreement. So it was all done in the right way with the right consultation process. The benefit, though, I must stress, is where we can have better data sharing across organisations, that will help our patient journey, and it will help minimise and reduce those extra long waits that some of our patients have, where we can try and equalise the demand across our providers sector in NCL. And to the second question, so it's a very good question and very topical given the news that came out over the course of last night. I think where we are now is we've got some tremendous learning over the last 18 months. And if we were to encounter another wave of COVID or something similar, I think we've got processes now in place where we would be much more better equipped to deal with another pandemic like that. So there are certain thresholds and limits. So if we do get something to the degree that we've had over the last two waves in the UK, of course, that will have some impact on elective services, but I don't think we're now in a place where we have to completely shut down all of our non-essential elective work, because we found protocols and we've got infection prevention guidance and rules and policies that will really help keep the public safe within our services, but also keep as much of those running for as long as possible until we have to scale them down if we get to a point where the levels of COVID get to such an extent that we have to divert resources elsewhere. So I think we're in a far better place. We've also got ring-fenced elective centres now. So the new one I mentioned around UCLH, only elective work takes place in that. We also have Chase Farm in our suite of sites across NCL. That's only an elective site as well. So again, ring-fenced for elective capacity. And there's other parts of our system where we do have ring-fenced elective capacity, where only work like this will take place and would have been mixed with sort of non-elective COVID work, and therefore we will be more resilient against future waves. But as I'm sure we all are, we're hoping that this wouldn't materialise into something as significant as what we've seen in the past.
Okay, thank you. And I've got Councillor Tomlinson, and then I'll ask a couple of questions. So if anybody else wants to put some more questions in, then please raise your hand so I can take them. Thank you.
Thank you. Thank you. There is a mention on page 104 of community diagnostic centres, and I'm just wondering what hopes you have for these centres. It's a very exciting development in a way, but it's yet another new thing which patients might not, especially be drawn to. It's hard to say. What is your hope for that facility? And also, I want to ask about resilience and the supply of vitamin D. This has come up locally, and I don't know what our policy is throughout North Central London on the supply of that. Thank you.
Okay, and the couple of questions that I have, thank you, Councillor Tomlinson. So on page 85, I'm just checking that I think you've got them down as assisted strategic pilots. So are those NHS-run pilots across the piece? I wasn't sure, things like Consultant Connect, I didn't know what these went, so I was just wondering if there could be a bit more information about what those were and who was running them. The question on social health and social care capacity, so you put that in as a pilot. Again, I'm not sure what's meant by that, and of course, as local authorities, health and social care is dear to our hearts, so if you could quickly, just very briefly explain that. Part of the report that I also noted, especially on page 93, you mentioned different hospitals that were struggling, some seem to be doing better than others in different areas, and I noticed colorectal surgery had dropped quite significantly on page 93. So is there any understanding, sort of a deep dive on what's going on there? A main question actually is staffing. So all these extra initiatives obviously will require staff to work differently or to work in a different way and maybe in greater numbers. Are you asking staff to do overtime in order to cover some of these different pilots and different ways of working, or are you actually getting extra staff? And then I also note there's a £20 million of funding on page 94. Is this new money? Thank you. There's quite a few, but I'm very happy for you to be brief on the answers. Thank you.
Sure, thank you. So firstly, on the point on the community diagnostic centres, this is a very exciting development. I agree with you. And I think the thinking here is if we can really bring our diagnostics together, and so we're not just talking about your CT scans and X-rays, we're thinking about broader than that as well, in terms of some of the ophthalmic and ophthalmology led pathways type diagnostics as well going into some of these centres. What you can really do is streamline how many touch points you need with an actual hospital service. So, for example, using the ophthalmology example, and this is being led by the Moorfields, which is one of the world's best eye hospitals. We're looking at whether we can introduce a diagnostic touch point in one of these centres, which means that if you are referred into the ophthalmology service, you will go to the diagnostic centre first, have your diagnostic there, and then you might not, depending on the result of that diagnostic, which is all done virtually, you might not need to go into hospital to actually have an outpatient appointment. That could all be done virtually. If, however, you do need to get called in and have a sort of follow-on treatment or treatment plan, then of course you would be called in if needed. But what this will effectively help us do is reduce the number of touch points patients would need to have with hospital services and really streamline those pathways. So we think it's better for the patient journey, fewer appointments, but really honing in on some really world-class diagnostics. So I think there will be, and I think your point's a very valid one, that as new facilities like this are being introduced, we need to make sure the communications are out there so patients understand, our GPs understand, and sort of the whole system understands on what their purpose is and how they'll be utilised. So I think we will have quite an extensive communications plan that comes around it. In terms of the next questions about the accelerator pilot, so I'll start with the money. So the £20 million, this is new money, and this was awarded to us this year as one of those national accelerator systems. it's a one-off pot of money to spend only in this year. So it's really designed for us to pilot some new ideas and then learn from them, and then decide whether we would want to carry those on in some form into next year, and also how we can actually share some of that learning with other parts of the country for them to also adopt similar sorts of innovations. So in terms of who's running these projects, it's the NHS. So we're effectively, as an ICS, we're coordinating all of those projects. There's 50 projects that fall under this. And it's being run by various either hospitals or primary care leads or community providers. So we've got different project owners for each one of those 50, but collectively we're bringing them together under the same umbrella for the system. The health and the social care capacity. So this is in a few different guises, but effectively it's about how the health and social care system can really help support the elective recovery backlog. And the main way is helping pull patients out of hospital when they're medically optimized to be pulled out and put them into alternative care settings like care homes, where that's deemed to be the most appropriate sort of next step for those patients. And I think by investing a bit more in those and investing in the teams that can help really coordinate and navigate those services, we can actually make these processes a lot more efficient and then free up capacity in hospitals in order to treat more people. In terms of colorectal surgery, this is a very good spot. The reason for that drop in performance recently is actually because the colorectal services across NCL have seen quite an increase in cancer referrals over the last 2 or 3 months. And what that's done is because cancer has a higher priority associated with it than the sort of normal elective pathways, more of the colorectal resources have been repurposed towards cancer to deal with some of the cancer demand at the moment. And then that's why the performance in the elective side has dropped off. We're wondering whether that's going to be a temporary dip. These things tend to go in cycles, and therefore once the cancer work stabilises, we'll then be bringing over the resources back to the elective pathways. And I think your point absolutely right on staffing. So this is our key challenge, I think, across all of this. It's not so much the money this year; it's more about the workforce. And we are working with our workforce in quite innovative ways, where they are able to, and there's no pressure on them to do so, but we are encouraging some overtime work as well, so we can run evenings and weekends to really accelerate getting through those backlogs. However, there is a key principle that we want to ensure we don't burn our staff out, especially in the context of what's going to be a challenging winter coming ahead. So we are trying to find the right balance between the two. And in some cases, we are recruiting new staff where they're available. In some cases, we don't have, even if we were able to, we're unable to fill those vacancies because the staff isn't there. And that's where we have to work with our existing staff base in more innovative ways. I think I've covered all the questions, but please let me know if there's anything I've missed off.
No, that's fine, and thank you. And based on the questions and the answers given today, I have to say a really useful and informative report. I'm sort of thinking about recommendations from the panel, and I'm sort of the stresses that I can see, and I think it's been highlighted, is around workforce. As you've said, you've got new money in. It's more about the stresses on that workforce. If you haven't got them, you can't deliver. So I'm thinking about whether we look at workforce as maybe a future agenda item and sort of bring in some of the pilots, or some of the, especially on the health and social care, which is more in our remit, particularly because to me it sounds a bit like discharge to assess, and that there's that 6-week funding where the NHS is paying, CCGs are paying for, funding for people to leave hospital at the moment. I think that first 6 weeks in a care home or a nursing home. But then, of course, it then goes back into the social care system, and then, so I think there's going to be issues and constraints in that area. So I think from this agenda item, it's incredibly useful to see how this is actually going to play out in the future. I think you're rightly said it depends on what happens with COVID, it depends on the workforce, and it depends on the pilots and how well these can mitigate some of the concerns and issues, because we know that up and down the country, many people are hugely concerned about the long waiting times that they are undertaking. We haven't really got into that today. So I think we as a panel will be thinking about whether we need to take this back in sort of 8 months' time to have a look at, has this actually reduced the waiting lists? Are these figures now coming through where you're saying, actually, councillors, we've now brought our waiting list right down, and we've fulfilled all these areas. It's all worked incredibly well, and everything's going well. And I think as panel members, I think on JOSC, that's an area that we are particularly interested in from our residents' perspective. Has this done what it said on the tin? And I think that's a good challenge back, I think. So I think in the sort of next 8 months, I think we will probably be asking for your presence again, and a report probably focusing in on has this actually reduced the waiting times, and if it hasn't, absolutely fine, but why, and is there anything else that can be done, and then focusing in on that workforce part as well, I think, because I think that's critical. But thank you, Ali. I hope that was helpful as a sort of a contribution from the JOS into what you're doing. It's huge, and we just really, apologies, we just haven't got the time to go into all these areas, but it's an enormous amount of work you're doing, and yeah, I would just want to highlight that. We do recognise that on the JOS. So thank you very much for that. I've got Paul with his hand up. So Paul, do you want to briefly come in?
Thank you, Chair. It was just to respond to Councillor Clark's question about the Pulse article, and that links to our advice and guidance service. So that service is put in place where there's a marginal decision from a GP about whether to refer a patient or not for an outpatient appointment. And we've been absolutely concerned about getting our referrals back to pre-pandemic levels, which they are now for both urgent and routine appointments. So we absolutely don't have a target to reduce referrals. And what the Pulse article was referring to, and it got it out of context, is that where a GP contacts a consultant for advice and guidance, 65% of those calls result in the patient's care being maintained in primary care appropriately, rather than ending up in a referral to an outpatient appointment. So the Pulse article was talking about one section of our sort of outpatient referral work, and we absolutely have no target to reduce referrals.
Thank you, Paul. Okay, excellent. So thank you very much, and thanks, Ali, again for coming on and for your comments. So we look forward to seeing you again. So I'm going to move us on now to the fertility policy review that we've been asked as a JOS to look at, primarily because there's a new draft policy. So obviously it's really important when things change across the 5 boroughs, that we as councillors can see how the policy is changing and how it affects our residents. I'm going to ask officers to come on and introduce the report. Again, just can I say that we will have read the report. There's quite a lot of documentation on this, so I'm not expecting you to cover it. Otherwise, there's absolutely no time for questions. So the majority of the time, again, can we have the questions and just a very brief, concise part. If there's anything specific you wanted to draw out from this report, you think is of huge relevance to us at this point, in order to make sure that we ask you questions that are helpful. So over to you. So if you could just introduce yourselves first. Thank you.
Thank you very much, Chair, and thank you, Committee, for having us today. My name's Penny Mitchell, and I'm the Director for Population Health Commissioning in North Central London CCG, and I'm the Director responsible for the work we're doing around these fertility policy area. And with me, I've got Dr. John McGrath and Fran McNeil. Do you want to both introduce yourselves?
Thanks, Penny. Good morning, everyone. Good morning, Chair. Good morning, Committee. Yes, thank you very much for inviting us. I'm Dr. John McGrath. I'm a GP. I'm actually Joe's colleague, so I'm the other elected GP on the NCL governing body. I'm the clinical responsible officer on this fertility policy review. And we're joined with Fran.
Good morning, everyone. My name is Francesca McNeil. I'm the Assistant Director of Communications and Engagement at the CCG, and have been the engagement lead for this piece of work.
So thank you, and yes, Chair, thank you for your summary and introduction there in terms of taking the paper as read. So we'll just highlight a few things about why we're here with you and how we've got to this point. And John's going to share with you some of the highlights about the policy and why we believe it's going to be beneficial for our residents. And then Fran will just make a few key points about the engagement window that we're now in, and then really be great to have some questions and discussion points. So obviously the fertility policy is a very small area of specialist services within the NHS. And whilst it is very small in terms of numbers, we estimate in North Central London that between 400 to 500 people per year will typically receive these very specialist treatments. We obviously know that it has a huge impact, often quite distressing and quite upsetting for the individuals, couples and their support network who it might be affecting. And it's quite an emotive topic for many people, both those receiving treatment and the wider population. So we're coming today together to further to a briefing that we shared with you in September about the work that has happened to date in terms of our overall fertility policy programme. The current position is that we do have 5 policies in place across North Central London, 1 for each borough, and that's a result of the CCGs previously being separate CCGs before they merged. There is variation in the level of provision and some of the eligibility criteria across these policies. And as a merged CCG, we've been very clear that we believe that having equitable access and supporting our residents to maximise their health outcomes is a real driver for a lot of work that we're doing. So these fertility policies cover the very end of the pathway, the very end stages of a journey that a couple or an individual might find themselves on if they're struggling to conceive a child. And there's many other types of treatment, investigation and support that will be provided prior to these end stages. So if someone feels that conception might not be progressing as expected, but say the policy is very much focused on these specialised treatments. Now, the most common, the most well-known one of these is IVF, but it's important to recognise that the fertility policies also cover some other crucial treatments, such as the preservation of eggs and sperm. For example, if someone's undergoing cancer treatment that might impact their future fertility. So we shared in our briefing note previously, and we've highlighted again in report, that we've undertaken a thorough review to understand the latest guidance, the evidence base, our current activity and our expenditure levels. And what's been really fantastic is the feedback that we've received from both a specialist clinical group from across our providers in North Central and just outside North Central London, and also the engagement and the feedback and suggestions that we receive from residents and service users. And that's all in some of the detailed reports that you've referred to. So I'll pass over to John to give you a few highlights about the proposed draft policy next.
Thanks, Penny. And Chair, I take your point about wanting to use our time for questions, so I will be brief. I mean, there's a lot of papers, so well done for getting through them. I think I'm aware there's hugely technical language that is included here. And I think certainly from a GP's perspective, sometimes a bit of time and familiarity with this means that sometimes I go too fast or I use jargon. So please do ask questions at the end of this if things do need clarifying. I think there's a couple of points I'll draw out. And number one, it isn't just about looking around North Central London, picking the borough that has the perceived most generous policy and applying that equally to the other boroughs. This has been an exercise in looking at what our current population needs are, working through a review policy, hearing from the public what's wanted in terms of recommendations, and the clarity of wanting to have a single policy which is equally usable no matter where you live. I think that's the thing I'm probably most proud of being able to present as this single draft policy. Probably the most useful thing to look at, I'm looking at the supplementary agenda, it's page 15 on the pack that I've got. It's the colourful table is probably the thing to draw your attention to in terms of setting out the draft policy, so what we're suggesting, how that compares to the NICE guidelines, which is the, I guess, the best evidence base about where we should be aiming to get to. And I think highlight number one is that we've been able, for the majority of the boroughs, being able to move much closer to that position of sort of national excellence. And that is a great thing to be able to do, and is not the same when you look up and down the country. I think the other thing to pick out from that is particularly around IVF. I think we've been really keen to listen and to hear. That's been probably the single biggest area of feedback that we've got. We talk in the proposed policy about embryo transfers rather than cycles of IVF. And I just want to really highlight why that's important. So an embryo transfer is taking a genetic material, so sperm and egg that have met in the laboratory, implantation into a uterus in terms of aiming for a pregnancy. And each time that you do that has around a 30% chance of success in the best prognosis individuals. And if you do that 6 times over, your chance of ending up with a successful pregnancy is greater, much greater than 50%, almost towards 80%. This is about giving people who qualify for this, who meet the criteria that indicates that you're likely to benefit from a procedure, the best chance of a successful outcome. And I think that's the other key thing to take on. And then the final thing I think I'll just really highlight around is about IUI. So this is intrauterine insemination. This is about trying to introduce sperm, so genetic material from a man, to a female egg inside, so inside a woman. And that has been a real issue. You may have seen some of the media reports, particularly in same-sex female couples, around the perceived unfairness that's of having to fund that yourselves. And I think we've moved to a much more modern position, a much better position, something that I really feel very confident in terms of engaging with the public about, in terms of our ability to fund that. And allied to that has been this agreement in the proposed policy to fund that genetic material, that donated genetic material, which is required in some of those circumstances, which really is hammering home this point about not mixing public and private funding for NHS treatments. So those, I think, for me, are the main sort of clinical things which have come out of it. It's been a real pleasure to be involved in it. We've worked, as Penny has said, with a group of specialists from our local providers. That's our clinical reference group. We've had external clinical scrutiny from a professor from out of area to try and provide an independent voice. And we're about to tell you about our plan for how we're going to engage with the public around our proposals and demonstrate how we've listened to that review phase. Fran, can I pass to you?
Yeah, thanks, John. I'll be really brief. I think a lot of information was included in the papers. Engagement's been a really important part of the fertility policy development programme. In the first phase, we sought to hear from a wide range of people, residents, service users, different community groups, fertility groups, other VCSE and clinicians to inform the recommendations that helped then scope the policy development. All of the engagement and the insights that were gathered through that were really carefully considered in the development of the policy, not just the policy, but also what people told us about their experience of using local services and also their awareness and understanding of what was available in the NHS. And we've considered all of that very carefully in developing the final policy. Now the second phase, engagement will be an equally important part. We launched our 12-week engagement period this week. We're seeking views as widely as possible on the proposed policy, but also importantly, how when we do have a finalised policy, we can ensure there's as wide awareness of that policy and understanding of how to access local services as possible. We'll be proactively promoting the engagement period ourselves, but also with our partner organisations such as the trusts to reach service users, local community groups and local fertility groups, and our practices and other clinical colleagues to seek the widest range of views, running open meetings, both online and face-to-face, focus groups, one-to-one interviews, as well as wide promotion of the survey. We'll be looking carefully throughout the 12 weeks about what we're hearing, including 2 meetings with our health watches to look at what we're hearing and who we're reaching through the engagement, so that we can tailor the approach that we're taking to increase the focus on any particular communities that we want to hear more from, or to look in more depth at any themes that are coming through the 12-week period. All of that will help to finalise the policy, but also, as I mentioned, then make sure that when we are at the point of having a policy, that we continue to then take care to widely promote it and help people to understand how to access specialist fertility services in North Central London. I'm very happy to take questions on any of that.
Thank you. And I'm going to just start with Chair's prerogative to just say thank you to all three of you. I have to say, I thought this was an excellent report. It is very detailed, so there were quite a few documents for everyone to read. But I did really like the themes that you drew out from the engagement. I think page 13 that I think John mentioned about all the different areas and how you'll be, you're putting all those services together and I thought that was very clear actually. And I wondered if you're going to be using that as part of your next stage in your engagement, because I think it's really helpful for people to see what was the previous offer and what now is being. I think that's an incredibly clear part. The questions, I just have a couple of quick questions to raise from this. One is, listening to yourselves today, there are some communities that don't necessarily engage with us as much as we would hope, or like. And I think through COVID we've understood that some communities aren't so quick to come forward, and especially around fertility. Are there any sort of communities that you feel you haven't reached in getting to really, so that they might not even engage at this point with the current fertility policy, just because it's an area that that isn't particularly widely discussed or known about, or advocated within people that they know and would have that conversation with. So that's one question to go back to probably Fran maybe about regarding communication. The second one that I had was on page 35. The primary care investigations. Now, whilst everything else looked really well structured once you got onto the secondary care aspect, the primary care information seemed to be a little bit more hit and miss about what investigations you've got. And we all know that different GP practices, have different ideas, and and I think again, Fran, it's the communication with the GP practices, but also from John, from your medical perspective. Is there going to be a streamlining of those investigations where you say, right, everybody has to have hormone tests, blood tests, whatever it is, before you get onto that secondary stage? Because I'm just wondering, in that primary care stage, could that possibly drag out for quite an extended period of time? Because I know that some people get quite a quick service, and sometimes it takes a very long time to get through those first levels of investigations. So is there going to be any sort of suggestions to your GP colleagues or primary care practice colleagues to say, look, we're expecting this whole process to take around 6 months or whatever it is? So that was a question. And then the final one for me on page 47, you mentioned, now this probably is just a point of clarification. It says about previous children as to whether you're eligible for this sort of treatment. And I think I don't know if I misread it, but it said that a previous adopted child is counted, and I think it said it counted as as a child. So, well, I couldn't quite work out whether, if you'd adopted a child, are you now eligible for future fertility treatment, or does that preclude you from that because an adopted child is taken as, you have a child? So that bit wasn't clear. So those are my first three questions, and then I'm going to open up to the rest of the panel to ask questions. But thank you very much.
Thank you. I think that's probably one for each of us to respond to. I'll start with the primary care pathway. So that flow table that you've mentioned is just an attempt, I think, to visualize that nice pathway. But you're absolutely right. The policy as we're presenting it is about the end of the pathway. So once you've had that diagnostic investigative stage to determine if or if not there is a treatable fertility issue which is causing problems. And there's lots of other treatments which don't sit within, officially this is the Assisted Reproductive Technologies Policy. Now, the great advantage about coming together as North Central London, the great advantage of having a single policy is that it allows you then to have a single flow chart for suggested pathway of investigations. And we're not presenting that work to you today. This is sort of the thing that enables that to happen. But I guess to answer your question, is there an intention for that to happen? Clearly there is, and that would be a clinical pathway that we would want to have standardisation of offer across North Central London. I think the issue around the issue about when to start those investigations, the NICE guidance is quite clear around that, and how long do those investigations take is slightly dependent on some of the things Ali was talking about waits for diagnostic procedures and tests. For example, this week I got an email from UCLH for semen analysis that has got a delay in how long that's taking. So some of the primary care aspect of it is dependent on other bits of the system. So I think it's hard to completely answer your question, but hopefully to try and give the reason that the table can't be more specific at the moment is because we don't have a single policy yet. But by doing that, we sort of unlock some of these other things that we can potentially do. Penny, do you want to pick up the bit about adopted children?
Yeah, thank you. So yes, to provide clarification there, an adopted child is considered the same as a biological child because of that legal process. So if a person, an individual or a couple has an adopted child, a formally adopted child, they will not be eligible for treatment because they already have one, and we are prioritising for those where there is no living child.
And just on the third question around ensuring that we are hearing from a diverse range of our communities, absolutely, that's our commitment. We've got around a list of around 100 to 120 community groups that we're primarily going out to. We hope that they will identify connections to other groups that we can have conversations with. In the first phase of the engagement, quite a lot of the feedback was come back to us when you've got a policy. It will be more easy for us to kind of provide you with feedback. So we should see kind of a wider range of engagement. And in terms of the materials that we're producing, we do have some easy read materials that are slightly more straightforward to kind of digest. One of the themes that came back in the first phase was that it's although we will offer translated materials if that's helpful, it's not necessarily just about translated materials, but kind of actually providing information in ways that are kind of tailored to different community groups and the information that they would want from us. So we absolutely would work with those groups to provide information in a variety of ways. I think it's important not just through the engagement period, but beyond that. I think a lot of what we'll learn is how we can kind of post the policy publication actually continue to promote awareness and understanding of what's available in kind of culturally competent ways, including addressing some of the kind of cultural specifics around stigma or the cultural needs from services, not just for the CCG, but also we're making sure that what we're sharing, what we're learning with the trusts, so they can think that through in terms of any information that's provided by the trusts and the services themselves. So I would very much hope that when we bring if we bring a report back at the end of this, that we'd be able to demonstrate kind of what that's delivered in terms of a breadth of feedback.
Thank you. So very quickly, Fran, just to say, have you got any understanding that there are particular groups that are currently not engaging with, this area as a whole? So, I'm just going to pick, so one particular type of group. Are you sort of saying, well, it's really interesting that for some reason we're not getting referrals from people who are, I'm going to say Welsh, I've got some Welsh heritage, so I'm going to pick that as a, but as a random sample. So, are we saying, that there are groups that are currently not engaging? And if so, have you got that? Are you then looking at trying to get, in touch with those particular communities specifically? Sorry, I know that's quite a detailed answer, but it's just something I'm really interested in. And then Councillor Tomlinson, thank you.
We do have data on service users by ethnicity and at a London and I think an NCL level. Penny might come in on that. I think we're trying to go out as widely as possible, but absolutely we're informed by the kind of the data that we've got.
Okay, thanks.
Chair, shall I just chip in there? Yeah, it's really interesting, and the HFEA produced a report earlier this year which gave much more information about particularly around ethnicity and the use of fertility services. The reality is that, like so many services, actually trying to capture good ethnicity data is quite difficult, and it's often not to the level of detail that we would like. And actually our NCL data, in terms of doing this exercise, it certainly hasn't got that level of granularity that we would like, and we will continue that discussion. I think we're obviously building off the previous other engagement on other services, around COVID and where we've used it. I think the other thing to highlight is that one of the community members that we've had as a member of our steering group, Kaltun, is from a Somali background and is closely involved in sort of Somali women's groups, and particularly around employment and other issues. And we've been working with her and sort of seeing how can we be a bit more innovative and try and think about how we reach to these groups, because she's had conversations in exactly that point where people have gone, we didn't even know we could access some of this support. So it's really difficult, because when we don't hear, we don't necessarily know that the groups are there. But I think everything that we're trying to do is just to find those different niches. I think we've branched out, we've done a bit more on Instagram, we're putting more online, etc. So I think we're just continuing to explore, and we'll continue to learn through that.
I've just one of the things that really has grown through the COVID response programme and the vaccination programme is connections into a lot of grassroots organisations that I think previously, before the pandemic, perhaps the CCG didn't have. Penny mentioned Somali, but kind of Turkish, Greek, Eastern European, Bulgarian, Polish, Roma, traveller community groups. So our connections I think, are much wider now, and we're certainly using all of those to kind of to try and instigate conversations about the policy, but also about people's access to and experience of services.
Thank you very much. Councillor Tomlinson.
Thank you, Chair. On page 15, there's mention of the second half of the 2021-2022 financial year, an increased efficiency requirement, which will continue to increase into the following year. And it's the first I've heard of this particular efficiency requirement. How will that be measured? I mean, this raises quite an interesting question. We're talking about people here, and I should think that efficiency with people is quite hard to measure. And also a quick comment on adoption and fertility treatment. I'm wondering if that is really going to satisfy a lot of patients, because, well, I recognise that there's a greater need the needs are driving the service that we want to provide. But a couple might be absolutely desperate to have a child, a biological child, and have turned to adoption as a second route. But it doesn't mean to say that they still don't want to have a biological child. So I'm wondering if that policy can be reviewed. Thank you.
Okay, thank you. If you could take those questions first, then we've got Councillor Clark to come in. Thank you.
Sorry, Chair, I didn't quite hear that. Did you want me to respond to those two questions? Thank you.
Yeah, apology about my sound. Yes.
Thank you. So I think we've included that information there about the financial context, and obviously understanding that as you well know, the NHS is under significant pressure, and thinking about efficiency as the whole system is going to be core for us and will be a national requirement. At the moment, we don't, I think, have the level of detail yet about how that will apply in different areas. I think it's really important to say that actually through the work that we've done and the modelling we've done, which we have taken worked with our financial colleagues in the CCG and taken to the Strategy and Commissioning Committee as part under the governing body, is that this policy will see, we are expecting to see an increased spend on these fertility services, because we think it is the right thing to do to increase access to these services in an equitable way, and to ensure that we are the policies say it's based as closely to national and best evidence guidance as possible. So I'm sure there will be more discussions. Will certainly, in terms of the fertility and wider gynecological services, we'll be thinking, as we do across all our services, and particularly the point of an ICS is to think about how we deliver all of that in conjunction as a partnership, and where in both we can have service improvement and service efficiency. But we're not claiming any thing at the moment, and say at the moment we are forecasting an increase in spend. Just coming back to the point about adoption, it's really interesting to hear your thoughts on that, and we'll be capturing that, and it'll be interesting to see, obviously, from other residents how they view that as well. And it's something that we can absolutely consider. As I say, I think the priority, and it is fairly standard that the approach in these policies, particularly if a child is part of a family in a formal way, either through biology or through adoption, that is considered a living child, and therefore the priority goes to those who don't. Now, obviously, that doesn't take anything away from the distress or the journeys that individuals and families have go on, but that's really interesting to hear that view, and I'm sure we'll hear from others about that, and I'm sure we'll be coming back, and so it'll be interesting to share with you where else we might have heard on that topic.
Okay, thank you very much. And Councillor Clark.
Yeah, yes, it's a very detailed draft policy, really well done. And just wanted to I noticed on the chart that was pointed out on page 14 or 15 about the different boroughs, and just for information, I'm not sure what Islington is the only borough that does embryo transfer, and the others have sort of frozen embryo and fresh, and I just wondered why Islington is sort of different in that way, because I'm just a bit ignorant about fertility treatment. But the bit that is really easy to read is like your engagement and the results from the engagement. So I just wanted to pick a few things out of that, because one of the things was the inclusive language, and so you're obviously going to address all the things that have been picked out there. But I noticed like there's there's a difference in access to the services by BMA people. And that on page 68 it has the actual stat that 67% of people using the service are white and 30 something are BME, and how are you going to address that that issue? And then there was an interesting bit of feedback about waiting rooms shared with maternity services, and that could be distressing, and I'm sure you'll be addressing that as well. If you could say something about, this thing about 3 miscarriages before you qualify, that seems really hard. I don't know if there's a comment there, that it's distressing. So those are my points. I'm just very, I'm learning about fertility treatment. Thanks.
Shall I answer just in terms of the trying to ensure equitable access through different communities? So one of the things I'd be delighted to bring back, and we'll be developing towards the end of this phase, will be a communications programme to support the introduction of the policy. And I would see that having several different aspects. One, work that the CCG would do itself to ensure that we are kind of widely promoting in inclusive ways and with activity tailored to reach different communities, reflective of what we know in terms of access to over the first year of the policies, and on an ongoing basis, to try and ensure that we have reached and help people to understand and navigate into, through primarily general practice, these services. A second part of it, I think, would be that GP education piece, so that GPs are aware perhaps of any inequality in access and can be kind of proactive through their initial conversations around trying to provide that advice and guidance about what's available. And thirdly, I think through an ongoing partnership with our trusts, one of the positives I think through this first phase is creating a network of clinical trust kind of connection across the services that we commission, and look at what we can bring from what we hear from the engagement that can be used by trusts then to help to ensure that pathway into specialist services is culturally competent and addresses any kind of barriers or things that may be putting people off from continuing in that pathway. We're not at the point where we have that plan drafted, but that would be the three kind of key elements that I would see in it, and would be very happy to share it with Joska at that point.
Thanks. I'll try and pick up on some of the technical points, because you're right, Councillor Clark, it is very technical, and being completely honest with you, it is about becoming increasingly familiar with the terminology, and I've had to do that over the course of this as well. So I think the point about 3 miscarriages came up during our clinical reference group discussion. I think the separation of recurrent miscarriage, which has a diagnostic pathway, may have alternative treatments, which may or may not eventually need IVF. Separating those two clinical issues out, I think, is challenging, and it does confuse it slightly whenever they end up included in the same report. So I'm sorry that they're there. I think what I would say to any patient of mine who is experiencing or suffering from recurrent miscarriages is not to assume that IVF is going to be the only possible outcome, and clearly it would be an option for some, but there is a really clear diagnostic pathway involving our specialists that should be gone through first, because there's other treatments other than IVF which would be suitable for some people within that category. The issue around why are there differences between our historic or current at the moment policies, I think is a great question. I think, you know, that is the ignorance I have as an Islington clinician about why things look different in different boroughs, but clearly these have been different organisations having to set priorities, do individual fertility policy reviews previously that have ended up with slightly different language. And that has created, I think, the central issue is that we have this differing level of policy across our 5 boroughs. And that's, I think, what we're trying to set out to achieve in the end. The specific comments about what's the difference between an embryo transfer and a cycle of IVF. So a cycle of IVF is sort of the whole thing. So ovarian stimulation for the lady, collection of eggs, selection of the best egg to choose, fertilizing that in a laboratory using either donor or partner sperm, the reimplantation of that into the uterus, and hopefully the successful continuation of a pregnancy. The sort of the magic bit of it, the bit that actually, you know, gives you the chance of a pregnancy, is the embryo transfer. And I think Islington's trying to set out a policy that sort of gives you a recognition of how many embryo transfers you can expect to have funded. And that really, the learning that we've got from certainly our current specialists and our out of area colleague who's been commenting and helping us with it, is I think that's where these policies are likely to go to across the country. It's just setting a little bit more clarity about an embryo transfer as being the unit of likelihood of success. So I think it's probably a more modern phrasing compared to some of the historic language which is being used. I think those were the technical issues. Apologies if I missed any of your other questions.
Well, John, I was just going to pick up on also the comment that question you raised, Councillor Clark, about shared waiting rooms, and it ties in with the miscarriage point as well, which is it was an absolute privilege to hear some of the stories and the level of sharing that we received during the first engagement period. And people were really very willing and shared just very powerful and obviously quite upsetting stories about things that they'd gone through. And, you know, we are really grateful for that openness and transparency, because it helps us to hopefully make this better and do our job as effectively as possible. And as you've picked up, quite a lot of the feedback, unsurprisingly, because as soon as people are sharing, they're sharing about their whole experience, aren't they? And the distinction for some people, you know, about a very technical policy versus their whole experience of doing something, that all gets mixed up. So we're really keen that in our recommendations report and our engagement report from that review period, we wanted to make sure that we captured that wider feedback about service experience and patient experience. Now, what we've done is we've acknowledged that that does not specifically feed into the policy aspect and that work to do. And we are at the moment prioritising that policy development, because if we get that right, that does open a lot of doors for people. But what we have absolutely done and will continue to do is that we've shared all of that feedback with our providers, with that specialist clinical group. We've obviously shared it with the chief execs and the medical directors of all of our trusts. We've issued a specific reminder, particularly around the psychological support and the guidance from the HFEA that providers of this treatment should be providing. And again, we've signalled that as we move into an ICS, there will be themes and topics for us to pick up around that service user experience and how there can be those improvements. So is it all going to be done dusted straight away with this policy? No, but do I think we've really built a really great platform and a network for continuing this and supporting that wider transformation? I really do think we're on that journey.
Okay, thank you. And due to time, and I have to say it's not due to lack of interest in delving further into all the work that you've done, I'm going to be bringing this part of the agenda to a close. There's a couple of points that I'd like to draw out from your presenting to JOSC today, different areas. So one is around the, and I think we've heard today about the confidence in making sure messages are passed through to the different groups and using those voluntary sector organisations. And Francesca, I know it, you know, this isn't just to yourselves. I mean, this is an excellent engagement. So this is not a criticism. It's an understanding that actually it has been quite difficult sometimes to reach different groups. And I heard what you said about your the connection with the Somali community. And I think if in the next iteration we see a sort of wider understanding of what other groups you've managed to sort of speak to in that respect, because I think there is that. It's whether we have confidence that these groups actually understand there's a fertility policy in the first place, let alone a new policy coming out. So I think for us, that's it. And there's also a conversation around how you would capture the views of people who have adopted a child, but actually really would like to undergo fertility treatment. And I think that's been drawn out from today's discussion. And I completely understand the comments around, I think Penny made around the financing, but I think that group still needs to be captured and heard. And you know, if they're not, then that next stage around financing that could never take place, because their views are not actually being captured. So I think that's really important. The bit about financing, I think that's been pulled today is, again, it's really hard. It's really great. We're looking to sort of scare or sort of offer up, I would say, across the whole piece. And you go sometimes above and beyond the sort of nice guidance in sort of making sure that, you know, different services are sort of brought further, you know, up to what people would actually want. I think my concern is again around the funding. And you've mentioned that actually you're going to be asking for an increase in funding, where we know that there is a pushback around, you know, how much money is available. So I think the question from JOSC is, what happens if NHS, you know, England turns around and says, actually, we're all going to have tighten our belts and across the board, and actually, although this fertility policy is excellent, we're now going to reduce the funding by X. What would happen at that point to your policy? And the final bit is around, and I think John, about the GP practices and the primary care system. I completely take your point that you need to do the policy first and then ensure that how that is communicated out. But I think within that policy, I think, you know, if there's an understanding that there are other treatments available for different things, making sure that all primary care knows this, so that people aren't left in limbo for a while, having to go to different services and finding they're in the wrong one, and then working out. And you were saying about the miscarriages, you know, there's a different treatment protocol for, you know, what would be going on there rather than going straight into this. I think that's that sort of confidence that's clear. And then the confidence around the timescales around the primary care investigations. I completely understand that there's a huge pull on different resources at the moment, and that's really difficult to do, but I think some guidance once the policy is done. I think that next steps part, I think, is really important, that that's also looked at and not lost when the policy is finally out and up and running. So I think from Joss, that would be. I hope that's captured the comments that I've made today. I'm going to look to my colleagues to see if there's anything else they wanted to add on that. I've got John to come back in the meantime.
Just to say thank you. Yes, I think that's a really clear sort of summary about what I've taken away from today. I wanted to make I caught the end of the first discussion. I just wanted to make an explicit link to this is the type of thing that clinical advice and guidance can be really helpful for primary care, to ask questions of specialist colleagues without needing to wait for, this backlog of appointments. So there are huge benefits of communication between primary care and secondary care, specifically to try and avoid some of the things that you've just mentioned. So thank you for inviting us here today, and hopefully, I know it's really technical, so thank you for bearing with us.
And thank you. I'd just like to say again, it was an excellent report. I'm really interested, I'm sure the rest of my colleagues are, in actually that final draft. So I would love to see it. So please do sort of send it back to us once you've got to that final stage, because I think it's a really important piece of work. And I think it really highlights actually some of the really in-depth work that you have done around community engagement, Francesca. So I would like to say that has definitely been noted and appreciated. So I'm literally just nitpicking at that last bit. So it is just that last extra, request from Joss that we are, but having read it all in detail. So I'd like to thank all three of you for coming on the call today, and we look forward to seeing that final policy and in all its glory, hopefully. So thank you very much, and I shall say we're now on to the next agenda item, which is on winter pressures, which is agenda item number 9. We've got Paul Sinden, the Chief Operating Officer, NCL CCG. I've got Alex Fawkes, Head of Urgent and Emergency Care. I've got Darren Farmer, Director of Operations, Ambulance Delivery and Emergency Operations Centres Transformation, who covers North Central London, so quite a mouthful. Apologies to just the panel to note, within this we've got the verbal update on the e-consult that wasn't in the reports pack, so I will be asking that that's probably discussed. I know I don't normally ask for a long discussion on an agenda item, but as we haven't seen that would be really useful. And from Darren, hopefully you've got some figures around the hospitals, in particular about waiting times for ambulances outside the different hospitals within NCL. I completely understand it wasn't available for the report earlier, but that would be really helpful if those could be brought up at this point before we go on to questions. But again, please leave a lot of time for member questions, because I think this one's going to be quite an in-depth discussion. So over to you, and I shall let you introduce the reports. And yeah, we look forward to hearing. Thank you.
Okay, thanks, Councillor Connor. So I'm Paul Sinden, Chief Operating Officer for the CCG. So if I do a brief intro, and I'll try to weave in the primary care piece from earlier and e-consult. So in terms of our priorities for this coming winter, firstly, it is to maintain the safety of our urgent and emergency care pathways, and sort of picking up in particular on that is reducing ambulance handover delays at emergency departments. And the focus on reducing those ambulance delays is underpinned by clinical risk for those patients being best managed in a hospital and not in the ambulance. Picking up on the elective recovery piece as well, maintaining our elective recovery over the winter, and capacity in particular to eliminate all waits in excess of 104 weeks or 2 years. So sadly, we have about 400 people waiting over 2 years across NCL currently. I'm sure, and I think that will be picked up at the JOSC subsequently. And then finally, the third priority for us over the winter is to maintain the rollout of the vaccination programme for both COVID and flu. So 3 sort of broad priorities for us over the winter. I suppose the next bit is the context for some of our plans for this winter. So we have seen an increase in primary care and urgent presentations across our system. So general practice appointments, NHS 111 calls and low acuity attendances at local emergency departments are all above pre-pandemic levels. 6% of our general and acute beds, that's about 150 beds across North Central London, are occupied by COVID positive patients. And we expect that this level of hospitalisation will continue over the winter. And that really means that 2 or 3 wards at all our main acute trusts are being used for COVID positive patients. And this adds to trust pressures from the need to separate pathways for COVID and non-COVID patients and follow infection prevention control guidance. So Ali mentioned that that guidance had reduced our elective productivity by 15%. 20% of our critical care beds are occupied by COVID positive patients, with 75 to 80% of those patients not having their vaccination. So hence the importance with continuing with the vaccination programme. And high occupancy of our critical care beds is a risk factor for elective recovery. We do have high bed occupancy across our hospitals in North Central London. So the average occupancy locally is 96% against a London average of 92%. Some of that accrues from people spending longer in a hospital bed more recently. So NCL hospitals have about 21% of people in a bed who have a length of stay over 21 days, and that compares to a London average of 17%. So this is one of the reasons why our bed occupancy is high in NCL. In terms of, even though our A&E attendances have gone up, our emergency admissions haven't gone up compared to pre-pandemic levels. So a constant level of emergency admission compared to pre-pandemic levels. And that high bed occupancy is one of the reasons why we are struggling with our ambulance handover times at some of our units. And then finally, in terms of context, so we'll set some of the urgent care pressures, some of the sort of hospital pressures we've got. But the COVID pandemic has increased exponentially how trusts locally provide mutual aid. So that includes for the elective recovery programme that Ali talked about earlier. We've established a North Central London critical care network to make sure that people needing a critical care bed always get one, and by balancing the load across our hospital trusts, but also operating to escalation triggers. So recognising where pressure is increasing in one part of the system and doing our best to mitigate that. We talked about primary care earlier, and one of the things that we do with our practices is we do what we call a SITREPS or situation report, and that is self-reporting by practices, and we do that every 2 weeks. So the idea being that we get an early warning from practices that are struggling. And our latest snapshot shows that all practices are offering face-to-face appointments. We've had a lot of concern about whether practice doors are open, and we've had about 7 practices out of 200 indicating that their door wasn't open, or people are accessing through an intercom, and we are working with those practices, including on infection prevention control guidance, to enable them to open their doors. Practices also report to us on staffing constraints, and about 20% of our practices have indicated a constraint in particular around admin capacity, and some of that accruing from, I suppose, adverse patient reaction to sort of access. So many of our practices sadly reporting abuse through our SIT reps. We have had the Winter Access Fund for primary care, so we've received just under £7 million in North Central London to improve and extend capacity in primary care over the winter. So much of that money will go to practices to extend same day access into practices, and we are putting more support into areas of NCL with the highest level of deprivation. So 3 primary care networks in Haringey, 1 in Islington, 1 in Enfield will be receiving additional support through the Winter Access Fund. We're also trying to provide at-scale support so that we can use these funds effectively and take pressure away from practices where we can. So that includes putting more capacity into our extended access hubs in each borough, and within that making sure that those extended access hubs are offering face-to-face appointments for children under the age of 5. Also extending our remote monitoring capacity for people with long-term conditions and COVID, where that can be appropriately done at home, and also extending links between practices and community pharmacies through the Community Pharmacy Consultation Service. So practices referring people with low acuity problems to community pharmacies for their care and treatment. I mentioned that many practices are raising admin capacity concerns, and we are working with NHS bank partners to allow practices to access admin support from bank partners, but also provide the customer training that Joe referenced earlier. In terms of e-consult, that was introduced at the start of the pandemic to maintain access. When I talked earlier about practice appointments being greater than they were pre-pandemic, appointments have gone up by 15%, the latest figures, compared to before the pandemic, albeit with a different mix of face-to-face and virtual appointments. When practices are responding to e-consult, that is over and above the 15% increase that I've just mentioned. The service, the e-consult service, is set up in a way that flags patients on the severity of their answers that they provide, and I think that was some of what Councillor Cornelius was talking about earlier. And depending on how people respond to those questions, people will be diverted from e-consult into 999 for emergency diverts and 111 for urgent diverts. And that divert percentage is about 5% currently. And our team working on e-consult in North Central London has met with the providers and with 111 to better understand how patients are red flagged and diverted. And we are developing mechanisms to understand where patients go after using e-consult. So what I've talked about was that direct divert by e-consult, but we are looking at mechanisms to measure people's onward contact with the NHS following e-consult, and that would be, you know, the volume of practice and emergency department reattendance, the number of contacts per patient. So working with the e-consult providers to try to refine the service offer that they provide. The report kind of sets out a series of service developments that we're doing, how we're working with mental health services to make sure that people don't go to ED when they have a mental health problem, So crisis
cafes. Paul,
yeah.
I'm just going to interrupt you here. Sorry, thank you. So it's really helpful to get an update on the new stuff, and I think you've covered that. If you're going into the report, just because of time, I'm really conscious that we're time is ticking on quite considerably now. So, and we've got other speakers. So, is there something specific from the actual report you want to very quickly address, or are you happy for us to go on to others on the call?
Apologies. Yeah, I'm happy for you to go to others on the call. So I think the list of developments is in the report. Sorry, I didn't mean to hog the time.
It's fine, thank you. I'm just very keen to hear from everyone on the call that's come in today to speak to us. So before we start taking questions on the report that Paul's spoken about, we've also got Darren on the call and others. So is there anything that you wanted to speak to us, Darren, from the London Ambulance Service and Alex? So yeah, over to both of you.
I'll start really quickly. Effectively, we've seen a massive increase in demand on our services between 15 and 20%, and a lot of that demand sits in northeast London and north central London. So that has absolutely impacted on our services. Also, as you'd imagine, during a pandemic, there's been a systematic move away from public transport to private transport, which has had a significant impact on us in terms of journey times. I know you called out wanting some data on hospitals. So in terms of the hospital breaches that we've had in the month of October, 450 over an hour at North Middlesex, 459 at Barnet, 333 at Royal Free, and then 159 at Whittington and 48 at UCH. What I really need to point out is those were October figures, and we've been working on a new process with colleagues both in the acute trusts and in the system across North Central London, but across London as a whole. That's been trialled the last 2 weeks and is moving into business as usual from this week, and it smooths that activity and reduces those delays. And so what we've seen across London is about a halving of those hour-long delays, and it's an iterative process, so I'd expect to see that improve as we go through into winter. Clearly demand is going to increase, as we know, and we're already seeing the early signs of that, but it is a rosier picture for November than it was in October in terms of hospital delays, and we are seeing improvements. Is that quick enough?
Thank you, Darren. Sorry, I don't mean to sort of say to everyone you've got to do it in 3 seconds, but it's just I know that members have lots of questions. So really, it was just new information for the councillors on the call today. So, but thank you, that was really helpful. I didn't quite catch one of your last figures, but we'll pick that up later.
I can share the data with you all. Yes,
that would be lovely. Thank you, Alex. Over to you. Thank you.
Thank you, Councillor Connor. So nothing really to add that Paul hasn't already covered. I would just say for the NHS 111, we have seen significant activity over the pandemic, and certainly over the last year. We're seeing about a 30% increase in calls coming through to NHS 111. Now that means that we are receiving about 610,000 calls per year, or we're forecast to this year. We've made significant provision for that from March to the end of the year, with recognising further increases over winter. And just to say that at month 7, we are pretty much bang on track for activity versus our plans. So we feel we've made good provision there. One of the key issues that NHS 111 providers are experiencing across the entire country is the staff retention of call handling staff. So these are the front end staff that man the call handling services. And I know that Darren would echo that within 999 as well. So there are national programmes to try and mitigate some of that loss. So we have developed a staff recruitment and retention plan with our 111 service. That is working through quite well. We're expecting to see our staff back to full complement mid-December to mitigate some of those further winter pressures. So just wanted to outline that.
Thank you. And just checking there's no one else on the call that wants to bring anything up as part of the report before I go to councillor questions. So I'm just very quickly. Okay, excellent. I'll go straight into councillor questions then. I've got Councillor Cornelius. I don't know if anyone else wants to put their hand up at this point, but otherwise I'll just take Councillor Cornelius's question and then, yeah, thanks.
Thank you. Yes, I was just going to say that with the consult I mentioned earlier, when I actually did a little dummy session, it did take me 16 minutes before I got to press the button with submit. And obviously I didn't have a spot on my face, and I was just going through the you know, e-consult. But, you know, in the past, I used to be able to phone up my practice, and, you know, if you said it was really urgent, they give you an appointment that day. Or if you said, you know, I can hang on 2 or 3 days, they give it to me in 2 or 3 days. But they never asked me a whole load of questions that they did on the e-consult. And I appreciate you're now trying to streamline people, but I think 16 minutes to do an e-consult is absolutely ridiculous. And, you know, a lot of people would have given up the will to live. My other question is, or was not clarified, was I did phone up a local practice to find out what happens to these e-consult. And you didn't mention that in the presentation. Was one of the practices told me that they're now thinking of giving it up because it took a GP at least a day, if not 2 days a week of their time to actually go through all the 16 pages of my e-consult, had I submitted it, to then decide whether I'm getting a Zoom or an in-person, or I'm being told to go to A&E. So you haven't mentioned the GP time going through everybody's e-consult. So, you know, can you please confirm who goes through the consult and then tells me where I'm supposed to be going once I've submitted it or when I've got an appointment? If it is the GPs at the practice, that's a huge amount of their time. And that's why I've been told 1 or 2 practices are now wanting to give it up. And I cannot see why we can't have a very simple system. If GPs practices are no longer going to pick up the phone and you can't book on the phone as we used to, but as I said earlier, I haven't heard that GP practices locally have released any of their staff who used to book appointments on the phone. So if they're still there, presumably they're not going through these e-consult because they haven't got the medical knowledge. I was told it's got to be the GPs that do it themselves, in which case you're added on more time to the GPs going through the e-consult than the person on reception just giving me an appointment in the first place.
Okay. Thank you. Thank you, Councillor Cornelius. I think but I think just to add to Councillor Cornelius's thing around, because we're doing e-consult at the moment, I understood from the Health Watch, the Barnet Health Watch report, that there was a concern that because patients were not going through e-consult and had given up, that A&Es were picking up that patients were coming into them instead of going via their GP. Actually, that does raise, and if that's the case, then actually, is this something that you have picked up as colleagues in this area? And if you have, obviously that's a huge concern because of the pressures on A&E. And I think as ambulances are bringing in, but you know, can't unload because the A&Es are full. Actually, that's also going to be of considerable concern. So if you could just address that, and then we'll go on to the next set of questions. Thank you.
And Councillor Connor, sorry, it would be lovely to know if other health watches have picked this up. It can't just be Barnet going there, but the other 4 boroughs. Be interesting to see their feedback, or other councillors' feedback on e-consult, which I think is one of the most laborious things you have to complete. Thank you.
Okay. Thank you. So over to Paul and Alex on the call on e-consult. Thank you.
Joe, did you want to?
Paul, do you want to come? Yes. I mean, Councillor Cornelius, I can hear that you've obviously had a very frustrating experience with e-consult. And obviously, you know, one of the jobs that we need to do is to make sure that the feedback such as yours is played into any quality improvement methodology that we take forward. Obviously, you know, e-consult is an important aspect of how people can access services. And actually, you know, the problem is that we have problems with telephony. We are looking into new ways of making sure that we have new telephone systems. So that's something, a really big piece of work that's coming through at the moment. We also do have staff that are answering phones. I suppose I would feel saddened if you know, and I appreciate that you've had an adverse experience, and certainly if there are particular themes that you want to pick outside the context of the meeting, then very happy to do that. However, we do need to have a variety of ways in which people can access their GP surgeries. We do need to cater to our diverse population within North Central London, recognising that for some people using eConsult and these digital enablers are not enabling at all. So we absolutely do need to have up-to-date phone systems. We need to provide our staff with training so that they understand how to answer the phone and give people, you know, access to the best service first time. And that is all work in progress. And also the importance of not using eConsult as a way to gate access to general practice. And obviously the other aspects around that are making sure that when we train our GPs, that we're thinking about the role of telephone answering, the role of telephone triage, telephone consultations, the opportunity of face-to-face, and of course remembering that we do need to also offer choice to patients. And that's come through in all the conversations that I've had across the system. And as I said at the outset, it's about understanding in forensic detail what's happening across all our practices so that we can provide a bespoke intervention to solve the problems in each practice as they are arising. I mean, the problem is, I have to say, that we do have a bigger problem, and that is about the need for access to services, and that's not just health services. So many of you will have read the report produced by the British Red Cross, which was heralded in the newspaper earlier this week, which is really about the impact of austerity and poverty and deprivation and inequalities in our communities and how that is impacting on our residents. You know, so we have a significant problem with repeat attenders, people who are, you know, frequent users of ambulance services, frequent attenders in our emergency departments, people with long-term conditions for whom the exacerbation is often triggered by some of the things that are happening in their lives, which are to do with poor housing, employment, access to benefits, etc. So we do need to think as a system how we tackle some of these problems. But obviously, you know, within the scope of my job at the moment is how do we make sure that practices are using eConsult in a standardised way. Certainly, in my experience of using it, people are using it again and again and again, often with relatively minor problems. And the biggest problem that we have actually is that people have become so habituated to using the eConsult that they do often make contact for self-limiting problems which would have actually resolved on their own within 24 hours. So it is actually causing quite a problem in terms of capacity to manage eConsult. So on the other side of the coin, we've had to think quite innovatively how we also manage that. eConsults, however, do need to be triaged by doctors. They don't need to be looked at by, they should not be looked at by receptionists. It seems strange to me that you were asked some questions which didn't seem, which seemed dissonant to your situation, Councillor Cornelius. And obviously, you know, if there are glitches in some of these digital enablers, it's important that we do know about those because it should only be asking relevant information. And certainly some GPs are, you know, on a spectrum that goes from early innovators to, and I sometimes describe myself as such, so not others, but Luddite. So early adopters and people who find some of these things much more difficult to adopt. But certainly on the whole, the feedback from GPs is that it can be helpful in terms of having some of those key bits of information captured at the outset of a consultation before you then pick up the phone and speak to somebody. So we do need to think about these enablers, but we do need to make sure that they are enablers and not disablers, and that we still have the choice for individuals and how they access services. So it is continuous quality improvement is all I can say, and as into how we can make it better and more standardised.
Okay. Joe, you haven't really answered the question. Do you know how much time? You've admitted it has to be a doctor going through these e-consult. How much time it takes a GP per week to go through them, and then to come back to give the...
Well, we don't monitor specifically the time.
No.
In some situations, actually, it does help with productivity. So, for example, if you are able to request a prescription, for example, using e-consult, rather than waiting on the phone, rather than walking into the surgery, then that could actually be time saved. So we need to think about how different people use it. And certainly some GPs may find that they are getting a lot of e-consults, in which case we've put in place measures to support those practices. It just depends on the catchment area and what people like to use. So
well, I would have thought if they want a pharmacy repeat prescription, that's very simple. You know, you wouldn't have to go through the whole 16 pages of e-consult.
Indeed.
Get a repeat. Say that. That's a different matter. Sorry.
Well, apologies to contradict. I'm not contradicting. People use services in different ways, so we have to try to provide services for the whole of our population, and some people do, like, you know, some of the younger people like to be able to do things via email, and so that's helpful. It is helpful for many.
Could I also ask you, have you tried e-consult yourself?
Sorry, can I just say we've got quite a lot of other questions on the report, so I'm going to make some.
Jo would like to try e-consult for herself. With
just to assure you, I have, but I'm going to hand over to Pippa now.
Okay, sorry, I just need to make sure that all councillors are asked on all the report. I've got some quite interesting recommendations that I think are brewing, having listened to the answers already. I'm afraid I didn't get an answer back on the A&E attendance with the Barnett report. So if that's possible at some point to get an answer back on that, whether people who aren't able to fill out the e-consult, or are they going into A&E, and is that causing an increase stress into the A&E system? But I'm going to hand over, because I've got Councillor Tomlinson and Councillor Levy to come in now for questions on the whole report. Thank you.
Thank you, Chair, and thank you very much for the report and the very detailed comments by Paul Sinden, very helpful. I want to ask Darren, this is not touched upon in the paper, but locally we've had issues with attendance times at the hospitals due to the various cycling schemes and so on that have been put in our area. I don't know if this applies to the whole of North Central London. And I'm just wondering if you have any particular comments on that, because it's very frustrating for our residents, but it's also the fact, for the case, I believe, that you're not routinely consulted on these changes. And what I'd like to see going forward is that you are, because a number of these schemes are being proposed as permanent changes. So I'd just be very interested in your feedback on that. Thank you.
Okay, and we got Councillor Levy.
Sorry, I'll be quick, really as quick as I can. It's back to e-consult again. Observations, and I've heard everything that Jo has said, and I acknowledge a lot of it, and I think it comes under the category of the best laid plans and all of that, because I think the intention behind it and the motivation and the desire to see the change in the way that people access GP services is, of course, necessary and has been accelerated by recent times. But in effect, what is happening here, and it seems to me like it's very supply side driven and not demand led, is that it's been introduced far too quickly, because what it is actually doing is effecting a culture change amongst the community and the population. And at the moment, I mean, Alison's example is an example, but I'm sure there are others, and of course there are going to be some positives as well. But the issue is, and Jo, you said yourself, we've got to get the infrastructure in and the telephony in and consistent quality improvement, which actually suggests to me that it's been rushed. There may be issues of uniformity about how the doctors work with it, but I'm talking about in the round. Has it been rushed in too quickly because of the fact that people weren't able to go into surgeries, and that one didn't get all the ducks in a row to make it more effective? And then there's a tail chasing thing, such that if people get adverse experiences, we go to Councillor Connor's point that when people give up or lose the will to live, they then put more pressure on the ambulance service for calls that aren't needed, or go to A&E who are overwhelmed because the ambulance are calling it. So there's effectively, if you like, an Escher diagram of activity going on here. So my observation is that, well, I suppose I've made the point. Is it, have you actually created a rod for your own back, or is the NHS creating a rod for its own back in that trying to do what it wants to do to change the accessibility? Sometimes a culture change takes a generation. We're trying to actually do this in 6 weeks, 6 months, even a year. And so I understand, Joe, what you said. I'm more worried by what you said, and I'm not sure that eConsult is the solution. I actually wonder if it's contributing to the other problems wider, especially under this item, which is called winter pressures. Is eConsult actually a cause and not an effect?
Okay, thank you. Okay, so two separate answers or two separate questions and different areas. So over to you. Thank you.
So shall I pick up, Councillor Levy, your really interesting reflections? You are, you are essentially correct about the complexity that the NHS finds itself in. And today we've heard a number of themes. We've talked about elective backlog, haven't we? And we've talked about ways to try to access specialist opinions. We've talked about the winter pressures, and we've talked about general practice services and everything that general practice is doing to try to alleviate the system and provide access. And that then when that fails, then we also have the pressures on LAS that you've heard Darren describe. You are completely correct that this is a very complex problem. And to say that there's one solution that's going to solve the problem is very difficult. Remember what happened during COVID. The system closed down and managed COVID. General practice services had to turn on a sixpence in order to be able to provide some access to services for patients, some access in whichever way they could. The system had to turn on a sixpence, and in fact GPs were incredibly resilient and fleet of foot, and we were told to adopt these digital enablers in order to be able to provide some of this access. And that's how we managed. And we did the best that we could. And we continue to do the best that we can. And we have incredibly high levels of demand now. Sorry if I'm speaking too loud. I can imagine it must be, to have me booming in your ears must be awful. But you see, and you are completely correct, of course, that we do need to make sure that we are providing that access. The additional problems are that we have a population now who effectively was not going out over the last year. So the winter viruses are increasing exponentially. Respiratory conditions are increasing exponentially, both in adults and in children. We also have a generation of parents with young children who maybe have first-time children who are incredibly anxious and find it difficult to manage some of the normal respiratory problems that would normally be managed. So we've got an increase in the number of children that are also presenting. At the same time, we are still managing very high levels of COVID, and we are absolutely not going to step down our elective activity. So what we're seeing is a system with a huge amount of activity going through it, coupled with a huge demand. And you are right that eConsult may be making access incredibly, maybe duplicative. And we do need to understand some of that. But we also do have to manage the fact that people want to access services every which way they can. So to say that we're going to solve this overnight would be a fallacy. We need to be very careful. We need to be measured. I absolutely agree that, we've had to adopt some of these remote methodologies in order to keep something going. And of course, GP appointments have increased by about 15%, 15%, whereas in fact, we haven't seen similar increases in activity in other aspects of services. I was reminded yesterday that we've recovered our elective capacity up to 86%, certainly not 100%, even though our target is to go higher. We remain a system under pressure. And yes, we are very anxious about the next wave of any new variants of COVID. So I think in the pause that we have, it will be important to go right back to basics to understand how practices are using some of these enablers. You are right. I do not want practices using e-consult as a means to access contact with their GP. That is wrong. Continuity of care remains important. Having a face-to-face assessment is important. And everything that we're doing is trying to work with practices on a one-to-one level to actually make sure that you as patients, I'm a patient, I live in Haringey, that we can access the services that we need when we need them. So, yeah. And I have elderly relatives as well. So I do get the whole pathway.
Okay, thank you, Councillor Levy. I appreciate you have to step out now, but I've taken on board your thoughts and we'll be bringing those back as I think recommendations at the end of the paper, as long alongside everyone else's on today. So I've got Councillor Tomlinson's question to Darren in the London Ambulance. Thanks.
So thank you very much for the question. The simple answer is that contact is different across each borough of London. The number of incidents we've had in Camden is comparatively low, which is why we haven't necessarily pushed in the same way as we have in other boroughs. So we have really strong contact in Enfield, where we've had a great many more incidents. I guess the other thing to call out is that there are two different schemes being provided by two different providers. One is the low traffic neighbourhood scheme, which is done by individual councils, and then there are the cycle lanes that are being integrated by Transport for London, and I'm guessing that might be where your question was angling. So engagement is absolutely key from our perspective. We recognise the need to address the two separate issues here. One is the climate change emergency. The other is delivering care in a COVID world. And unfortunately, we're trying to do both at the same time. We're trying to drive traffic away from our streets at a time when people are uncomfortable using public transport. And that's the challenge for us. So I think the simple answer to you is as I acknowledged earlier, we have absolutely seen a reduction in road speeds across London. We have specific issues, but not a high volume in Camden, I would say. However, there has been an impact, and we continue to work with both local councils and TfL to manage that and ensure that we can get to our patients in a timely manner. I hope that answers your question.
Okay, thank you, Darren. So just very quick follow-up on that. So are you part of that initial consultation phase when these initiatives are brought to the fore, so you can provide impact at the outset?
So my understanding is that we are a required stakeholder and therefore are consulted. I think we need to recognise that a lot of the original consultation processes were done during the very first peak of COVID, when our workload was huge, and the availability of LAS staff to respond to some of those inquiries was probably challenged. But I think I would describe us as an active stakeholder going forwards. We are supportive and understand the rationale, but obviously we want to make sure that we are still able to deliver quality care to the people of North Central London.
Thank you. So I'm going to ask a couple of quick questions. So Darren, you're on the call today. So you mentioned the numbers that were literally halving for handover. Apologies, I think that's what you said, because you initially gave us some quite substantive figures for people who are having that 1 hour delay. So can you just unpick a little bit more about what this initiative is that's resulting in it? Because I was concerned that maybe it was a staffing, that whether you had enough staff on, whether you had enough ambulances, whether you had enough call handler people, to take those calls and prioritise them. So can you just literally tell us how you're halving these problems? Thank you.
So the simple answer is in collaboration with the acute trusts. So we know the situation that we face, which is that there are a number of trusts that are at their maximum bed occupancy, which means that cascades back down into their emergency departments, and they, like us, are seeing huge increases in their demand and the patients that are presenting to them. So actually what we've done is identified those trusts that are most challenged. So in North Central, that was Barnet and North Middlesex. We've worked with the chief execs of each of those trusts to identify some additional capacity further to the south of the area. So what we see is that the number of delays is at its least in University College London, and slightly less in Royal Free and the Whittington. And so effectively what we've done is we've repurposed some of the boundary areas between those two in their catchment areas so that we can move some activity to the less challenged, and it's almost a cascade down North Central towards the centre, and into Camden and towards Westminster. And we work with them to ensure that the patients that we're moving are those that are least likely to require admission, because we know that there is an impact for delay discharge if particularly frail or elderly patients, or those patients who've got a recurrent condition. So this is very much about patients who sit on the boundaries between two hospitals being moved to the less challenged hospital in a proactive way, rather than the more reactive mechanism that we used before. And that is what we've seen creating results. It's an iterative process, and we intend to make it business as usual from next week to reduce that. I hope that makes sense.
It does, and thank you for that explanation. A very last quick question to yourself, and then one on mental health. Because I know you've recently undergone reconfiguration of services where you've had to sort of amalgamate different services together into one. Has that made any impact at all, or does is that literally just where the ambulances come back in the evening or when they're not being used? So that's a quick question to yourself, and then one on mental health actually in this winter pressure report. On page 111, I noted it said that people who use with mental health issues are discharged to within the social care system. I'm just wondering what that actually means. Does it mean that we have increased specialist facilities within the community for discharge? Is this to out of A&E into a mental health trust that's effective? So a very quick question on that sort of mental health discharge, because I just wasn't quite clear where people were being discharged to. And it says investment in support workers to discharge patients effectively. I think regarding the homeless sector as well. Again, the homeless sector, discharged to where? And again, I'm assuming there's specialist sort of supports, accommodation for people that are homeless, and just really understanding about, are there other services that are then put around that person if discharged into the community in order to prevent further sort of escalation of mental health issues and continuing going backwards and forwards into the A&E system. And I think that's obviously just a little bit more clarity on that. But just to yourself, Darren, about the reconfiguration part first. Thank you.
Okay, so the reconfiguration was a response to the initial wave of the pandemic. We've now deconsolidated a lot of our sites across London, predominantly because of the need to increase our capacity based on demand, which you touched upon. I think it would be fair to say that we have a long-term ambition to move to a more consolidated, centralised model, but that is a long-term ambition rather than anything that we have any clear plans for right now, and there are no plans for any further changes within North Central. It's difficult to identify whether there's been an impact one way or another through the consolidation, because so many things have changed at the same time. So initially a huge increase in demand and some safety and risk issues around the availability of protective equipment, and that was the predominant driver for the original consolidation. Last summer, we saw a really quiet period after the original peaks. There just hasn't been anything consistent. So I think it would be fair to say that actually it's had very little impact on the service that we deliver, but it did allow us to protect our staff during the initial surge in the pandemic. And now we're very close to the model that we were using pre-pandemic. Hopefully that answers the question.
Yes, thank you. Mental health issues, Sarah, thank you.
Thanks very much. Just for those who don't know me, Sarah Mansrally, Director of Strategic Commissioning. Yeah, some good questions with regard to mental health, and I think, Chair, this really responds to recognising the impact of the pandemic, particularly for patients suffering with mental health disorders, and recognising that A&E is probably not the right place for them at a point of time of crisis. But equally, on the point of discharge, what we do know is that many mental health patients kind of experience long lengths of stay and extremely protracted inpatient stays, quite often because sometimes the out of hospital pathways, shall we say, are not sometimes there. So what we've done is we've had a bit of additional funding for mental health winter pressures. What we've done is worked with our colleagues in social care and housing, but so that actually what we can do is establish better pathways to things like supported housing, so that that capacity is there in the system for patients that need it. So we are actually supporting patients who need social care placement sometimes through this route. Just recognising that sometimes the cost of these placements in the short term are quite difficult for councils. Just recognising some of the challenging kind of care home and kind of care sector situation that we face across health and social care. I think the other thing that we're really trying to do is to support multidisciplinary team working around discharges, so that patients actually get discharged with the right package of care and the right support in the community, so that what you don't see is that bouncing in and out of ED, because that's clearly not going to help their long-term condition, but equally the immediate crisis point that they face. Have I answered that sufficiently for you?
Yes, I think the concern that comes in local council perspective is around people getting that right support, and whether, and I think there's always a concern once that person is back within the community and under the primary care services again, is if that person doesn't then interact with mental health services. It's the ability for any commission service then to go out and proactively be able to engage with that person, because obviously if these issues escalate again, then they're back in A&E and it's a cycle. So I know that's it's particularly probably a small cohort and it's probably very specialist, but it's just something that I think we're just really concerned about, that we actually have a little bit more information on and just a bit more confidence that actually those services can interact with that person, and that that they're able to be, it's more sort of positive rather than reliant on the person with the mental health issues to actively engage and actively allow and actively sort of go out back into the primary care service. So it's how those two are joined up, I think, it's particularly helpful to understand.
Yes, I think really relevant, because actually ongoing community support is really important. And we talked about the developments that were happening around community transformation, but also some of the kind of additional roles in primary care, which are there really to support mental health patients with mental health needs, becoming much more integrated with primary care. But we've also got, and I appreciate the point about having that the patient themselves having to access services. So there is that ongoing element of support from the community teams. But equally, I think our lower level crisis provision has significantly improved over the last 18 months. with things like crisis cafes available in each of the 5 boroughs, but also really simple to access crisis lines. So I think in the past before you could have kind of accessed crisis lines directly, you were actually having to present to EDs, you were having to go into crisis, like quite intensive crisis services. Whereas I think we've got much lower level of crisis services available across the 5 boroughs now, which means, yes, there is a need for ongoing support to those being discharged, but equally those who find themselves relapsing can also reach out quite quickly obtain support in a way that wasn't possible previously.
Thank you, that's really helpful, thank you. I'm just going to look for further questions because I know we're running a little bit over time, so I just want to make sure that I've asked all the councillors on the call if they've got any further questions before I sort of do a brief summing up. No, okay. So thank you. I also had a kind offer from John to come in about e-consult. He wanted to just come back in on that, I think from his own experience. So John, over to you, but short and sweet if possible, thank you.
I'll try my best. Yes, thanks. I just think e-consult is, I came up yesterday as part of a public meeting that I was doing in Islington, and I just wanted to try and make it clear about what it is and what it isn't. And Councillor Cornelius, you've typed in the chat bar a wonderful way of how to book an appointment using an electronic platform. E-consult is not designed to be how to book an appointment. It is an example of what's called an online consultation. It's got an awful name, which is an asynchronous online consultation. E-consult is one of a number of proprietary products that the NHS can choose between, and there's a mandate for us to use it in order to try and offer access to a wide group of people. The way that e-consult works is there's a clinical algorithm that sits behind it, so there are lots of questions. It's a bit like when you call NHS 111, there's a list of questions that people have to go through, and the control of the clinical assurance of that process has a process that's been gone through. I think the how to book an appointment, you make a really good point, which is people should be given an option of how they want to access, what the way that they do it. E-consult is probably not the only solution for that, and you've heard Jo say really clearly that she doesn't feel that that is the way that general practice should be offering people that choice. But what e-consult does do is offer a level of clinical assurance going through someone's particular problem. And what it does do is it asks some of those questions that you will get asked whenever you come through to a GP had you not gone through that e-consult process. But just really to make that point that e-consult is not how to book an appointment. E-consult is an option for an online consultation, which may or may not include medical questioning. Thanks.
Councillor Cornelius, really briefly, if you want to obviously come back to that,
Can I just answer that when I went on this dummy run with my surgery, I am not allowed, I'm not able to book an appointment. I was told I had to go on e-consult. So if you're only thrown back to e-consult to get an appointment, and then I come back to my previous, you know, if I could have booked it before, have they made all these receptionists redundant? If not, what are they doing? And Jo Savage has confirmed that it is the doctors then that have to go through this. So if I want to get an appointment, and when I said, well, okay, I don't have internet access, so what do? I was told by my surgery, well, get a friend or get a relative to go on e-consult and book an appointment for you. Well, that's a bit of a shocker. It may just be my surgery, but it's not the only one in Barnet.
Well, I just to share, I'm sorry, so I'm registered in practice who again does exactly the same thing, and the reason I was given my own experience as a patient is it is very frustrating. I think what is clear is that there has to be an alternative to doing that. There is a product called eConsult Lite that you can be taken through via receptionist in order to walk you through those clinical questions, and I know that the practice I'm registered at does have that. eConsult is not great for children under the age of 5, which is what I was trying to contact them about, and eventually you can find a way to get through it. I think think your criticisms or the critique I've heard of it, I think are valid. I think there is work to be done on it, and I heard some of those themes that were coming through, which are part of what we're trying to do, to try and make sure that we use this as a useful adjunct for how people can access and ask questions, rather than as the only thing that people can use. And I just wanted to give you some reassurance that I've heard that as well.
No, well, that's where I'm coming from, because if I hadn't got internet, I would have just gone to A&E, because to ask a friend or a relative, you know, if it's urgent. And also I was so frustrated with eConsult, and I've heard this from so many other people. Frankly, I just get in the car and go down to A&E or my walk-in centre at Finchley Memorial, full stop. But then we're putting pressure on them.
Okay,
Thank you very much. Thanks.
We've got to the point, thank you, where we're all probably saying reasonably similar things on this part. Thank you. I just wanted to finish with, because Darren's obviously come on from the London Ambulance Service, a final quick ask from Darren. Just if there's any areas that you have got particular concern about. I mean, we've had some very concerning, information that comes through from on, the BBC app. I'm just going to put that out there that, I think we had Dr. Kathleen Henderson, the Royal College of Emergency Medicine, saying we're facing a crisis in care and urgent care and a crisis of patient safety. And I think that was, there was around concerns about getting recent reports about ambulances around the whole country, so not North Central London, but around the whole country. And I know there's been significant problems. So are you saying to us, Darren, that you think that actually, the ambulance service in North Central London is going to be able to cope with the winter pressures coming up, with this new system that you've got in place? You hope will halve the waiting numbers and more. Are you confident? Have you got confidence that this will allow patients to be able to access A&E in a timely manner? Or, well, not all, you might say yes, but are there any other concerns that you'd like to raise to the JOSC at this point, where you say, do you know what, actually there still is this area that we are concerned about, and it'd be helpful to sort of just keep a sort of watching brief on? Thank you.
So I think the simplest answer is the demand that we're seeing is one that the whole system cannot sustain. And what we need to ask everyone is to use all of the system wisely, only call us in an emergency, utilize the 111 system and local pharmacies. We need the help of everyone in London to get through what is going to be a very difficult winter. Obviously, it's early days in terms of where COVID goes next, and we don't know what that looks like. The challenge that probably all providers face is that the staffing that we are commissioned to provide is not in keeping with the demands that we've seen in the last 18 months. And that's not sustainable either. There's huge work going into increasing our staffing levels, into retaining our staff. But effectively, our staff are very, very tired. So anything that anyone can do to help in terms of managing down demand is going to be very well received.
Okay, thank you. That's really helpful and very clear messaging out to the public, but also again around staffing. And we fully appreciate all the huge work that you do in the London Ambulance Service and trying to keep the public safe and get to the right services at the right time. So we hear that message very loud and clear, and I think we fully support your request. I would say a strong probably push for extra staffing and extra support and support for your staff well-being, I would imagine, I think is all wrapped up in the answer you've just given. So thank you very much for that as a summation. I've got a couple of areas that I'm just going to pull out as recommendations from the winter pressures report that we've received today. Colleagues on the call, if you're able to come in and add anything that you would like to add to yourselves, or you have separate ones that you've picked up from today's call, that would be really helpful. But the ones that I've picked up on, I'm going to start with eConsult, because obviously that was raised both in the deputation and in the report and from councillors, so it's quite a strong, I think, push around the concerns around how e-consult is being used, and I think that probably might be the nub of the situation. We heard back from Paul about how I think you said about 5% of people that use e-consult are being redirected elsewhere, and I think you were saying about different work that is ongoing to try and work out, you know, does this number need, I think you said need to increase, and people need to be redirected, and I'd imagine that's to remove pressures within the service and make sure people are being sent to the right place. But I think the thing back from the JOS, the challenge back from JOS is to see, you know, how is that work going, and is that are you able to do that through e-consult? I think, is that the right platform for this work to progress? There's obviously a question around e-consult as being used as a triage system and as getting appointments. I think we've heard very clearly that there's been some real concerns raised. I have experiences from friends of mine, which I won't list them all now, but again, it's a similar concern that Councillor Cornelius has raised about this being used to get appointments, and I think that's where I think a lot of the issues are happening, about people maybe then accessing other services and putting pressure onto A&E and other services rather than using their GP practices. So I think as a recommendation from JOSC, it's around e-consult as a whole. It's around, is this the best platform? Are there other services that could be best employed in around asking GP practices to use just to get, you know, people that are phoning up, an appointment system, rather than maybe this is a more complex system for this to happen. And then around information back, from as Paul said, around, you know, is e-consult able to redirect people in the way that you are, I think, looking for, to try and you know, help within that to relieve the pressures and make sure people are sent to the right areas that they need to go to. So I think from a JOS perspective, that's areas of e-consult that we're particularly concerned about and would like to hear much more information back on. And I think about the London Ambulance Service, excellent. Thank you so much for coming to us today. I know you're incredibly busy, but it was really helpful to hear about what you're currently doing to reduce those hour-long waiting times outside hospitals. It's heartening to hear that there is a system in progress, and hopefully that will work. But do let us know, obviously, if it's a, you know, if it doesn't. I know it's difficult to report negatives, but sometimes that's really helpful so we can understand the pressures. But I think from a JOS perspective, there's I would strongly say as a recommendation from JOS that we are fully supportive of you know, increasing your staffing levels and increasing the support for your staff, so to help with their sort of well-being in what will probably prove to be quite a difficult winter anyway. So I think that's key from JOS. It really is useful to hear back that you are involved in the consultations around sort of road closures or any sort of lower traffic neighbourhood systems to sort of alleviate traffic pressures. But I think just to hear back that you know, that your service is involved at the consultation stage is really helpful to hear, because that is a concern that you can't get to some people quickly enough if those lower traffic neighbourhood systems are in place. So that was really useful to note. And I think, you know, that's it from the JOS report on your figures there, except I think there was one final bit around the capacity as a whole, and whether you think that, you know, in the staffing, if the staffing isn't increased, how much of your capacity will be affected? How much will you have to reduce services if you cannot retain staff, or, you know, staff continue to leave because of stress or other reasons? So I think that would be useful to hear back from you about, as well as the hospital, sitting outside hospitals. I think around primary care, that's quite a big part of the debate today, brought up in the deputation. I've looked at the deputation. There's some parts of that that are strong recommendations, and some parts of that I think are actions that the JOS can put back to our colleagues to see if we can have answers to, rather than just, you know, saying everything is a recommendation from that report, because there's really strong areas I think to pull out. Primarily for myself around the staffing, we've heard about admin pressures on that. And I think it would be really good to hear back about, I know that we've had, you know, Paul's told us about how we're going to try and increase our admin capacity and support our GP practices. Just some further information on how that is going, I think, would be really helpful. I think around the workload pressures, we completely have heard and we are fully supportive, I know, as councillors, about the pressures that our GPs and the nurses and all the staff are under. But I think there is a real concern about, some practices are fully open, some are, or sort of doors open, sorry, some are more reliant on things like e-consult and other ways of telephone triaging around patients. And I think we still need to keep that understanding of how that is going and making sure that all practices are working to the best they can with a cohort of people in their surrounding area. Because I think, it's very difficult if you're particularly doing telephone triage and the cohort of people around it are just more used to having a door access open policy. I take Joe's point that obviously COVID hit and there was a huge push to change, and I do know that there's been a massive increase in workload for the GP practices. So this isn't a negative, this is just to understand that all practices are being supported. So I think as a just what we're really keen to know is how specifically those practices are being helped. I did Adaptation brought out the fact that some GP practices across NCL were actually requiring improvement. I think it was 8, and then there were 3 rated as inadequate in Haringey. That was on the Adaptation report. So what actually are we able to do to help those practices, to enable them to make sure that they can provide a great service to their residents? So not also at the point where they're requiring improvements or failing, but actually the bit just before that. So we really need to have confidence, I think, as a JOS, that where that support is there. But actually, what is that support? I mean, we're told that the support is available. I'm not actually sure from the report what actually that entails. Now, I admit that's quite probably a little bit more detailed than you were anticipating. But I think for that confidence, it's like, well, are you getting other practices to buddy up with them? Are you putting in extra money? Are you commissioning different services via the CCGs or the new ICS, as it will be, in order to bolster different staffing coming into those practices to take the pressure off GPs and maybe, getting a dietitian in to take the pressure off. There's all sorts of different ways I'm sure you're doing, but it's really useful. And I think so as a JOS, there'll be a recommendation from us to get a much more in-depth understanding of that support level to ensure practices don't fail. I think that would be really key, or and that their patients aren't able to access them in the way that they want to. So I'm going to throw those my initial sort of thoughts around that I picked up from today on this work pressure agenda. I'm just going to look to my fellow councillors to see if they'd like to raise something now around any of those recommendations or add to them. That would be helpful. Thank you. Okay, I'm seeing happy silence, so hopefully good. What I'm just to be really clear is the deputation that's raised all the questions. What we're going to do with that is send those sort of in the bold, these are the questions and the feedback that we are particularly interested in. I'm going to ask officers on the call today, and I'm looking at Sarah and Paul and Joe probably in particular, to come back to take that paper and give us a written response to those, because I think from that, I think it's going to be really clear the areas that JOS either needs to look into in a bit more depth, or to add recommendations on, or just an action that I think would come from that. But rather than go through the whole thing now and go through line by line, I think that's probably going to be the most effective way of making sure we've captured the concerns that have been raised in today's deputation. So, and with that, I'm going to say thank you everyone who came to give us a report today. That was incredibly helpful. Thank you for your time and effort. I know it is much appreciated. It may not feel like it when we're asking the questions, but it genuinely is hugely appreciated that you've come on and give us your time today, and the reports particularly. So thank you, but I will keep councillors on the call because we have to go. We've still got the workload bit to do. just also before we finish this part of the meeting, I'd just like to say I've had apologies from Councillor Friedman and Councillor Moyed for different reasons, but those apologies have come into me during the meeting, so I just wanted to note those before we move on. But thank you to the officers on the call today. Thank you so much. And now we're going to move on to the final part of the agenda, which is the work programme. Thank you.
Pippa, I've got to go to the mental health meeting actually just now, but I'd be very happy to have a conversation afterwards with either Fiona or Rob and yourself around the forward plan, but I have noted quite a few things from today that I think you might want, but I'm happy to pick that up after.
Perfect. And Sarah, that's great. And we had a quick conversation earlier about the tracker, so just about the actions on the tracker. If you just want to very quickly give a quick response to that, and then yes, by all means, please lead to your next mental health meeting.
Thank you very much. Yes, so we note a couple of actions that are still on the tracker. Briefing papers are currently in progress, so we will have those circulated to members before the next meeting. So those should be closed off the tracker by the time we get to the next scrutiny committee.
Okay, thank you. And on that, thanks, Sarah. I had a couple of, just because I think the minutes, I think, were, I should have asked if everyone agreed the minutes.
Oh.
Does everyone agree the minutes that's left on the call?
Yes, that's fine. That's fine.
All right.
And thank you, Chair, for your excellent work on this and for everything today. And I fully agree the recommendations and actions. I'm afraid I'm going to have to leave you now, but I've had a look at the work program and I think things are looking fine. But it looked to me that I think the next meeting might not be fully occupied, so we may be able to shift things, but I'm really happy, and I think really thank you for everything, and the officers for everything today. Thank you.
Great, thank you, Councillor Tomlinson. Apologies for not agreeing minutes, so we're just gonna, I'm not sure, Fiona, you're probably going to say we're probably going to have to agree the minutes now at the next meeting because I did it at the end. So over to you. Is that what you're going to let me know?
I had one very quick comment, which is that there's a post-meeting note for those minutes, which is that the minutes from the previous meeting, so the 25th of June, under items for deputations, petitions, presentations and questions, all the references to Professor Sue Richards should actually say Brenda Allen. So just noting that that's a change to those minutes.
Thank you. And I've got a couple of, I think I was just going to say from the minutes from the last meeting, there was a couple of areas that I just wanted to clarify. I think they were actions, but they weren't raised as actions in the minutes. So I'm just going to send a written, there's only about 3 or 4. They're just, and they're not large ones, but I'll just write those and send them to Fiona and Rob to circulate. So they've got those to add to the minutes from the 1st of October. I think it just makes it clearer that what was actually being discussed. So that'd be helpful. So thank you, Sarah. Thank you very much for coming on. And thank you. So over to fellow councillors that are left. If there's anything that you wanted to raise as an area for our next meeting, because obviously we do have a space which we kept because of the issues around COVID. So I noticed we've got Councillor Cornelius on the call and myself. So Alison, I don't know if you're still there or if you want to come on. You might be silenced. Okay, so yes, in which case I'm going to say that I have noted from today's report particularly, there's a concern around workforce pressures. So we've had the admin pressures in A&E, we've got concerns around GP workload, workforce pressures, and we've also got concerns around workforce within hospitals. So I'm going to have a discussion with Sarah and other officers off the meeting from today, just to see if there's anything that we particularly need to be looking at as a JOS around this specific area of concern. if there's anything specific that is being done to address that, and I think there were things that were raised today. So, but I think that's an area that I think, and supporting staff actually, who it's, you know, it's been a long 2 years, and there's obviously huge amounts of pressures left to come, and with all this increasing in work that's been put through rightly from elective surgery and other areas, but it just shows that there's going to be a lot of pressure on the staff we currently have. So, and what can be done to help alleviate that. So that's an area that I think we may possibly look at for the January agenda item. But I'm very happy to take this offline now and have a conversation that Fiona and Rob, I'm sure, can put out to the councillors and see if there are any other suggestions. But with that, I'm going to look to Fiona. Fiona, have I missed anything else?
The only things remaining, there's no new items of urgent business, and the dates of future meetings are the 28th of January and the 18th of March next year.
Thank you, and apologies, and Fiona, do interrupt me next time and tell me I haven't done something like the minutes, because sometimes I get very carried away and go straight on to the report. So, okay, so thank you everyone that's left on this call. So I'm going to just ask Fiona and Rob to stay on just for the last couple of minutes.